My name is Veronica Ajewale. It is such a pleasure to have you join us for our program today as we discuss on prostate cancer. During the rest of this program, you would have an opportunity to hear from an amazing group of experts and panelists as we take a deeper dive into the whole concept of prostate cancer. We are also going to have panel discussion of lived experience as well as support system for individuals that have gone through treatment with prostate cancer. So write your questions, sit back, and engage with us. And I want to say a big thank you to all our speakers, our panelists, vendors, the partnering institutions, and most importantly, to each and every one of you, the community members, for engaging with us on this topic. We look forward to seeing you and continuing to engage with us as we work together to advance health equity on prostate cancer. Thank you and see you around.
Good morning, everyone. Good morning. I am Virgil Elkins. I proudly serve as the project manager for the Community Engagement Core for the Center for Biomedical Minority Health Research. Welcome to the third annual Let's Talk About Prostate Cancer. I have the esteemed pleasure of introducing our MC for today by the name of Minister Chris Johnson. He will be our Master of Ceremony. Chris Johnson has traveled across the spectrum of life to be brought into the service of Jesus Christ. Chris founded Prodigy Management Group, LLC, a full-service music and sports entertainment management firm where he managed and guided the careers of hip-hop artists. In 2012, God led him out of the entertainment industry and into full-time ministry. Chris is also the founder of Christ 180, an urban outreach ministry committed to the sharing of the gospel. He has earned a Bachelor of Theology degree and a Master's of Christian Education. In 2015, Chris was licensed as a minister of the gospel at the Good Hope Missionary Baptist Church here in 3rd Ward. He believes that the greatest three things about church is that we love God, we love all people, and we exist to change the world to make disciples of Jesus Christ. And also, I'd just like to say this is my good friend. Chris and I have worked together for the past 6 or 7 years at Good Hope Church. So I am proud and excited to introduce my friend, Minister Chris Johnson.
Thank you, Virgil, so much. Again, good morning to everyone. Welcome to this wonderful event. We're going to go ahead and get started. We are going to be bringing up Dr. Ivy Poon. Dr. Poon is a professional in the pharmacy practice and administrative department in the College of Pharmacy and Health Sciences at Texas Southern University. Dr. Poon received her doctorate of pharmacy from the University of Houston, as well as a Master of Science in palliative care from the University of Maryland at Baltimore. She is a licensed pharmacist and a preceptor in the state of Texas and has served as a clinical pharmacy specialist and preceptor for the pharmacy students at the geriatrics clinic in the Michael E. DeBakey VA Medical Center in Houston, Texas for more than 20 years. Dr. Poon has served as a mentor for many junior faculty in research and professional growth. Her research interests are geriatric and pharmacotherapy, palliative care, and pain management. We'd like to welcome here on this morning, Dr. Ivy Poon.
Thank you so much. Hello, good morning. How are you all? Great, great. I want to welcome everyone in person and also online to attend this very, very important event. Face to face, shoulder to shoulder, let's talk about prostate cancer. Prostate cancer is such a common cancer type, and yet it's so highly preventable. So today we are so excited. Are you all excited to hear about this? Great, great. So I love the energy around here. This is great and awesome. And so my role today, I'm going to go through what we're going to, our schedule and also some important housekeeping items. Then we'll just keep it rolling and listen to the speaker and everything. So you should receive a folder as you check in. So inside the folder, you will see a schedule with everything that we will have today. So we will mainly stay in this hall until around 1 p.m. Then we will go to the common area to get lunch, and then you will have a chance to visit the vendor and also the mobile units outside. While we are in this chapel hall, we will have speakers, panelists. It's going to be packed full of events, one after another, a lot of exciting things going on. So we want to say thank you for our sponsors and also partners and vendors. Thank you so much. And without them, we will not be able to host this event, will not be able to have this come alive. So thank you so much for coming and serving the community. Now, we also thank you for Progressive New Hope for allowing us to come here today. And it is always so excited to come here for several years now. So it has become like us feeling like coming home to come here to see everyone again. So thank you so much to allow us to use this space today. We are very thankful for that. Now, in your folder, you will see a notepad. As we are going through the presentations and panel discussion, if you have any questions, please write it down. Periodically, we will have Q&A. So when it's time for Q&A, then we will have you will have an opportunity to come up to the podium to ask us questions. If you are joining online, then you can write your comments in the Q&A box, and we will answer your questions. We'll bring up the question in front of the audience and answer it accordingly. Also, we will be passing out surveys. The surveys are anonymous. We are not collecting your names or any information. The goal of the survey is we want to know how you feel about this event, and also we want to collect any constructive feedback so that we can improve our programming for the next time. If you have any topics that you would like to hear more about, write it in the survey. We always review the survey to plan for the programming for the next year and beyond. And surveys is available through the QR code. If you use your phone, it will go to a link tree, then you will have access to the survey. We will also pass out the survey during the programming, and then if you get a copy of the paper survey, make sure that you drop it off to the front desk before you exit. So thank you so much for completing the survey in advance as well. Now, if you are a community health workers, you will need to complete two information. It is the survey and also the evaluation, CHW evaluation form. If you are gaining the free 2 credit hours of CHW credits, make sure you complete those 2 forms to gain your credit. All right, so I hope it's clear and we are ready to go. So I will give the mic back to the MC. Thank you so much, and enjoy the events today.
Okay, thank you so much, Dr. Poon. We'd like to call Reverend Kevin Alex to the podium. He's going to lead us in an opening prayer. Reverend Alex.
Okay. Thank you. Thank you. Would you bow? Heavenly Father, we love you, Master. We thank you, Lord. We adore you. We lift you up. There's none like you, dear Master. So we just praise you and we just worship you for who you are and the great things that you've done. We thank you, Father, for this vision and the vision of resources, dear Master, to meet the needs of the community, dear Master. We ask that you would bless everything that goes on here and that nothing will be displeasing in your sight. We ask that you remember everyone who speaks on the panels, those who have provided the things that we have here that will be used to uplift your people and your kingdom, dear Master. It's in the precious name of Jesus we ask it all. Amen. Amen.
Reverend Alex, thank you so much for that opening prayer. We would now like to have opening remarks by Dr. Ola Leahy.
Thank you. Good morning, everyone. Thank you so much for coming. I'm bringing greetings to you today from Texas Southern University on behalf of our president, our new president, Vice Admiral James Crawford III. They're currently doing the Congressional Black Caucus Conference and the White House HBCU Conference. Dr. Ajewole and I will be leaving shortly as well. So we bring greetings from them, as well as Dr. Michelle Penn-Marshall. Should have loved to be here. I believe she has a video. Our Vice President for Research and Innovation that has really supported this initiative. And let's give it up for Dr. Ajewole, please. You know, we can all have a lot of brilliant ideas, but if we don't have people who are great leaders that can actually execute. One mission that we have at TSU is to break down our walls and actually take medicine to the community, and medicine that's healthy for our community. That's going to be great intervention. So we're super blessed to have Dr. Ajewole as well as a great team. Please, if you're part of the CBMHR team, all the teams under Dr. Ajewole's Institute for Healthcare, please rise. Please let them see you guys are the ones doing all the great work. Mark just joined us. Come on, Mark, stand up, everyone. Thank you all for our staff, Cecilia, everyone, Dr. Ogbo, Dr. Poon, thank you so much, Jasmine, everyone. If I start calling names Olanike, I'll get in trouble. But we're so impressed. This is just one of the many programs that they run at Texas Southern University to really transform the lives of our community. This program is under a close to $9 million grant that we received from the NIH a few years ago. And it really literally took, so I'm glad we're in church talking about this, it took the hand of God for us to get that grant. You know the meaning of structural racism? That's what was happening. And the Lord literally fought for us, and we got it. And I'm so proud of Dr. Ajewole's team for running. And guess what? Guess what happened? I believe this April, it's been too many travels now, I can't keep track. This April, they literally, the National Institute of Health, the largest agency that funds health for the US, reached out to TSU for us to come and teach presidents, vice presidents in this country, provosts, on how to build research infrastructure in this country. It's all because they saw that other people were talking about this stuff, but we actually doing it. So we're so blessed. And in as much as we have a big center, we have researchers, we're doing science, all that science is not good if it doesn't really transform human beings. And that's what Dr. Ajewole and her team have done a fantastic job doing. And that's why we're here today. And I want to say a big thank you to you guys. Please clap for yourselves, because we can host all the programs in the world, but if the community doesn't come out, if our doctors don't come out to help us, there's nothing we can do. So we truly appreciate you. I will stop talking so we can get to work. Thank you so much. Thank you, Dr. Ajewole. So proud of you. Thank you.
Thank you. Thank you so much for the work that you do. And you could have kept talking. You could have kept talking. I'd like to bring next to the podium Dr. Ajewole. Dr. Ajewole serves as a professor at Texas Southern University and as a clinical pharmacist and an adjunct assistant professor of oncology at Houston Methodist Hospital. She received her PharmD from Texas Southern University and completed her oncology pharmacy residency at Houston Methodist Hospital. She is a board-certified oncology pharmacist with a clinical practice in oral chemotherapy Medicine from Houston Methodist Hospital Cancer Center. She is the founding director of the NIHMD-funded Community Engagement Core of Texas Southern University Center for Biomedical and Minority Health Research and TSU's Institute for Health Equity Advancement Research and Training. Dr. Ajewole is the convener of this conference. We are excited to have her present health equity programs at Texas Southern University. Please put your hands together for Dr. Veronica Ajewole.
Thank you very much, Minister Johnson, and good morning, everybody. How are we all doing today? It is such a pleasure to be here. Every time I sit and they are reading this, I'm like, Father, to you alone and alone be all the glory. I am super excited to be here. You know, this is the third time that we'll be having this conversation regarding prostate cancer. And I tell you, it gets better and more impactful every single year. So thank you all for joining us in person, and to all those that are online on Zoom, YouTube, Facebook, everywhere, wherever you are. Thank you very much for joining us this morning. My duty today is brief, and I will keep it brief. I just want to give a brief overview of some of the health equity work that we have the privilege of doing at Texas Southern University. My professor, my mentor, my leader, my sister, you know, she went up, you know, earlier, and please help me to appreciate Dr. Omonike Olaleye. I have had the privilege to know her, work with her for over 1 decade, and it gets better. I consider a catalyst. You know, you can try to do every reaction you want, but if you don't have that catalyst to help boost your impact, it makes your activities limited. So thank you very much, Dr. Monica Olaleye, alongside VP Penn Marshall and the entire leadership of Texas Southern University. Like Dr. Olaleye said earlier, we had the privilege of receiving this funding in year 2020, $8.6 million award, with the intention of establishing a Center for Biomedical and Minority Health Research that has positioned us to continue to advance health equity within the community. Texas Southern University has been blessed many, many years, decades, but, you know, with this funding mechanism, but prior to this cycle, we did not have a community engagement core. So what that meant was everything we did stayed within the wall of TSU. But by God's grace, when I came on board, I'm like, no, we're doing so much, you know, let's get it out, you know, let's get it out to the community. And that is really what we have had the privilege to do. Within the Community Engagement Core, we have 3 aims. One of them is to identify and address the health needs of the community. The second is for us to be able to raise awareness regarding clinical research for the community. And the third aim is for us to increase, engagement and awareness within the community. Again, as scientific individuals, you know, all my colleagues here can attest to that. We go to scientific conferences, but our community, they don't go there, right? And everything we do has to boil down back to the community. So really for us to have innovative ways to share information back to the community is very important. In doing these aims, we network heavily with FQHCs, churches like the church that we are in here today. Please help me once again to appreciate Reverend Atkins and the leaders of this church. Thank you all for supporting and engaging with us on this really important topic. We engage with elected officials, community partners all around, and we host events every month. Every single month we have something going on. Some of them big scale like this, some of them on the lower scale. We also engage with community health workers and also make sure that we are listening, right? Life evolves, the needs of people evolve, and how we approach and engage also evolves. So we do surveys, focus group, community engagement studios to help us to listen and take this back on our planning table to effectively deploy the initiatives initiatives that we have back to the community. All this that we are doing basically is encapsulated under the idea of the Institute for Health Equity Advancement, Research and Training that allows us to engage with sponsors, donors, strategic collaboration, innovation. So if anyone is sitting here or you are online and you're wondering, hey, I want to be a part of this, hey, I'm here. Dr. Ogbo is there, Virgil is there, all our team members are all around. We are very much open to partnerships and collaboration. So if you ask me why are we here this morning? It's September, right? September is Prostate Cancer Awareness Month. I say it when I go out. I say every day is a good day to talk about prostate cancer. But this is really why we need to have this conversation. The graph that we see here, we can see that blue, the second one, blue one that stands tall with the red box around it. The first graph is telling us about the incidence of prostate cancer among African American men. Pause and think about that. Then the second one is talking about mortality among African American men. We all want to stand out and stand tall, but not with incidence and mortality of prostate cancer among African American men. So that's why we're having this dialogue, to educate ourselves, to increase awareness, and to engage and ask ourselves the questions so that few years down the line, this graph will change. We need to be able to change the trajectory of what we are seeing here. So where the journey started was in 2020. You know, the first line in the Bible says, in the beginning, God. Permit me to say in 2020, God. So many things happened in 2020. Pandemic happened, but also in 2020, we were busy writing grants and getting a lot of funding. This $8.6 million award came in 2020, so also what this $250,000 that we received from CMS to address aggressive prostate cancer among African American men. I have the privilege to lead that initiative alongside Dr. Loud and Dr. Ndefo, and we had two major aims. Again, you know, centering around what can we do differently? How do we look at social determinant of health? How do we look at data? And we did not do it alone. It's not just, you know, us at TSU. We had a lot of collaborators. Houston Methodist Hospital. We had a community work group led by Dr. Asata Richards, and I see some faces in this room, right? Hello, sir, really good to see you. Thank you for joining us again. Dr. Kumenda and so many other men that joined us we had work group meetings every month, Saturday morning for 12 months consecutively during the pandemic, trying to have a conversation around prostate cancer. We worked with Community Advisory Board, with PharmD interns. But even when that fund ended, it was clear that we needed to do more. Dr. Komenda was like, Veronica, you need to keep writing grants. I'm going to sign. I will sign the letter of support, right? You know, everyone, they were like, okay, we need to keep doing this work so that way we keep our community engaged. This is one of the pictorials that came out from that work for us to say it out loud to our men, to say, hey, we want you here. We want you to stay around longer, healthier, and stay around with us. So that is one of the reasons why we are doing this, and I am excited because we have an amazing team of speakers and panelists today that will take us deeper and better into this conversation that we are going to have this morning. Again, the funding ended in 2020, but you know, God continues to make ways for us. AFLAC knocked on our door. Thank you again, Dr. Laleye, for answering that call. And we received more funding through AFLAC for us to continue doing this community engagement work. Not only did we get funding from AFLAC, but also more recently, this past year, we received $2.4 million award from NCI, which we used to establish the P20 Cured. Dr. Rafi is here. He's going to talk a little bit about that, his project on that initiative. Dr. Onta is also one of the pilot awardees on that initiative. And that grant is the only one funded in the United States for this cycle. So again, to God's glory, we continue to press forward to be able to do great things. One other initiative that I want to highlight real quickly is the EQB Med initiative. EQB Med stands for Equitable Breakthrough in Medicine Development. Because if we look back and we look at the number of representation and diversity in clinical trials for ethnic minority, it is very, very low. Again, we are doing a lot of work in the community. The EQB Med initiative now allows TSU to become a clinical trial site. So we are going to start having clinical studies at TSU. And recently, we just onboarded our clinical research coordinator, Mark, sitting over there. So he just joined us last week. And, we are taking a deep dive, into creating infrastructure and being able to bring clinical studies directly to the community. Hey, look at this, guys. Is anyone excited? This is a 45-foot mobile unit that will be on the streets of Houston a few months away from today. So again, very excited that we have the privilege to lead initiatives like this that will continue to bring health advancement to the community. I want to give a round of applause to everyone on our team. All these works that, we've seen will not be possible without the support of all our team members. The faces that you see on this screen, please, if you are in the room, can you please stand up for recognition and for appreciation? Thank you all so much. I appreciate each and every one of you. Thank you for your support. And there is a face that is not on that screen. Without the support of this person, I would not even be here. To God be the glory. God helps me. But without my better half, my best half, my one and only husband, Andrew, thank you so much for your love. Thank you for your support. Thank you for believing in me. He held the babies when I was writing the grants, okay? He did the diaper changes, gave the bottles and gave me the support and the grace. And I say it often, of all the grant-funded opportunities that I have, every one of them has an idea from my husband. He's my first focus group. So thank you for your love. I appreciate you. Thank you. Lastly, I want to say a big thank you to all our sponsors. Thank you to all the vendors. Thank you to all our partners, all our volunteers. Thank you, all the speakers and panelists. Thank you so much. And to all the community, thank you for attending. And I would step away and allow the sessions to begin. Thank you.
Dr. Ajawole, thank you so much for your comments. And Kev, thank you for holding those babies, man. You hadn't held the babies, we wouldn't be here. We're now going to transition into discussion around prostate cancer awareness and early detection. Our next guest is Dr. Curtis Pettaway. Dr. Pettaway is a professor of urology at the University of Texas MD Anderson Cancer City in Houston, Texas. His clinical practice is based on treating patients with genitourinary malignancies. I hope I'm saying that right. I'm not a medical doctor. Something like that. Okay. All right. Including penile, urethral, and prostate malignancies. Dr. Pettaway has served as the co-director of a National Cancer Institute funded study evaluating the influence of West African ancestry on the incidence and aggressiveness of prostate cancer among African American and Puerto Rican populations. We'd like to welcome to the podium Dr. Curtis Pettaway.
All right, let's see. Everybody see that okay? Yes. All right, fantastic. Well, certainly good to be here. Thanks to Veronica and the team at TSU. They certainly are a powerhouse, and when you get an email from Veronica, it's one of those emails that you just don't ignore, The answer is yes, so whatever she asks, you just do it, But you can see all of the things that they have accomplished, and I'm so happy to just be a part of it because This is the essence of what we want to achieve, building infrastructure to really make progress. So today I'm going to talk to you about prostate cancer early detection in Black men, why it matters. And so we're going to cover several different topics this morning. We'll start talking a little bit about just the anatomy. What is the prostate and what does it do? It's a walnut-shaped organ that sits underneath of the bladder, and its main function is during reproductive years to produce protein. One of them is PSA that helps to liquefy the semen so that the sperm travel more efficiently during reproductive function. So you can see it in the yellow here. It sits right beneath the bladder in front of the rectum, so you can examine it by placing a gloved finger in the rectum. The prostate will be right in front of that. You can also do imaging studies like an ultrasound or an MRI. We'll talk a little bit more about those later to image the prostate. How would you know that the prostate is producing any symptoms at all? Well, again, it's strategically located beneath the bladder, and the urine stream runs right through the prostate. So if the prostate becomes enlarged, it can basically begin to choke off that flow of urine. One can have a weak stream, trouble urinating. If the urine then backs up, bacterial overgrowth will occur and you can develop an infection. Symptoms of burning when you urinate, fever, frequent urination, things like that. Or just pain, pain in the area of the rectum, pain beneath the testicles, or pain in the front under the pubic bone. So the prostate is involved in three processes with respect to abnormalities. The prostate can become inflamed. We call that prostatitis. Very common cause of urinary tract infection in men under the age of 50. The prostate can be involved in normal growth around the central portion of the prostate. We call that benign prostatic hyperplasia. This is the growth of normal prostate tissue, but around the urethra, compromising the urethra, and then can produce those same symptoms. The prostate obviously also can be involved in prostate cancer. Now, this is the uncontrolled growth of epithelial cells of the prostate. They've lost their normal contact inhibition. They continue to grow. They begin to invade other structures, and they can also then begin to travel or spread to other places like the lymph nodes of the pelvis, retroperitoneum, or to bony sites. So today we're going to talk about prostate cancer early detection, why it's important in Black men, some of the early detection strategies we use, some of the clinical trial data that supports early detection. We also have to talk a little bit about the harms of early detection and how we can make early detection better and safer. And for the first time, we're actually going to talk about guidelines for early detection among Black men, which is very novel. So these are the data that we see for this year. Overall, when we look at the grand scheme of things, prostate cancer is the second most common cancer among all cancers, men or women. Fourth most common cause of cancer death. Now, when we look at men, it's the most common cancer. Over 299,000 cases are estimated for 2024. It's the second most common cause of cancer death. 35,000 men are anticipated to die of prostate cancer somewhere in this country during this year. Now, if you really think about that number, 35,000, and you break it down by day and by hour, that means during a 1-hour talk, 4 men are going to die somewhere in this country from prostate cancer. During this conference from 10 to 2, 16 men are going to die somewhere in this country due to prostate cancer. So this is a real problem. It's estimated that 3.2 million men have prostate cancer or are battling with prostate cancer in the country at this time. Now, for Black men, as Dr. Ajiwole showed us, the figures are even more dizzying. The incidence of prostate cancer is 73% higher than other racial and ethnic groups, and the mortality is twofold higher for black men. When we look at other factors that are risk factors like age, we actually have a nice breakdown here about two things: age and race and ethnicity, and how it affects prostate cancer incidence and mortality. Let's look at this curve on my left. We see as you get older, prostate cancer increases. We know that. Black men are seen in the purple curve. You see that their curve goes up the highest, greatest incidence. But an important thing to realize is that their curve goes up earlier at a younger age. Prostate cancer starts about 5 years earlier in black men. We see the same thing with respect to mortality over here. If you have prostate cancer, as you age, the likelihood of dying is greater. And you also see that black men have the highest mortality from prostate cancer, and they die earlier. So the current focus of research is trying to dissect apart the various contributions of why prostate cancer mortality is higher in black men. And it is multifactorial. A big thing is just access to health care, early detection, treatment, things like that. There are other things that we didn't want to realize, but are there. There are physician and institutional biases that may affect the content and quality of discussions so that one may not understand the conversation, they may not be accepting of treatment, or the treatment just may not be offered equally. Amen? So this is what we talked about before, structural racism, right? And then there's the other component, is that the biology of prostate cancer certainly suggested it may be more aggressive in black men. We saw that thing where it started 5 years earlier, right? So when you look at what the literature supports in terms of prostate cancer in black men, you see earlier disease onset. You see when men have undergone radical prostatectomy and they had similar clinical findings that the tumor volumes in the black men were actually a little bit higher. You saw an increased incidence of metastasis at presentation, certainly historically, maybe not so much now. But when you actually study the molecular features of prostate cancer, you often see molecular correlates of aggressive disease present at the DNA, RNA, and at the protein level. So early detection of prostate cancer in this high-risk population makes sense, doesn't it? Very good, very good. So what are some other risk factors? Heredity. This is a definition of hereditary prostate cancer. It means that members of a family with prostate cancer in 3 successive generations, like a grandfather, father, son, 3 affected first-degree relatives, 2 brothers and a father, or 2 first-degree relatives with early onset of disease before the age of 55. And we can see the effects of prostate cancer and heredity in this slide. You see the attributable population risk of prostate cancer in the dotted line. Now, what happens if you have one brother? Goes up twofold. What happens if you have a father and a brother? Goes up threefold. What if you have a father and 2 brothers? Goes up 5-fold. So clearly, something is happening in families, right? Now, it could be similar exposures, but that doesn't even explain the earlier onset of disease. It is more likely that it's something that is transmitted through families, like your DNA, right? Okay, so when we look at that, when you look at prostate cancer, we know all cancer is genetic, for sure, but it is estimated that about 58% of the risk of prostate cancer is attributable to inherited genetic factors. There are probably over 270 candidate loci on the chromosomal regions that are associated with prostate cancer. And to simplify it, we're going to just discuss these loci in terms of what we call lower penetrance alleles. I call those weak genes. and higher penetrance alleles. So the lower penetrance alleles are very, very common. These are found in population studies. 30 to 40% of men may have one lower penetrance allele, may have more than one. But if you get a lot of these together, and we call these single nucleotide polymorphisms or SNPs, if you have a lot of them together, they can increase your risk of prostate cancer. Now, what about the strong genes? These are higher penetrance genes. If you have one of these, you can definitely see a higher risk in prostate cancer. So if you have a higher penetrance gene, that means it penetrates and you're more likely to have the disease. Now, we know about some of these higher penetrance genes from studies in other cancers, like BRCA1 and 2. We know it's associated with a higher risk of breast and ovarian cancer. With respect to prostate cancer, if you have it, 2 to 8-fold higher incidence, higher grade cancers, cancers that have already spread, cancers that are associated with dying of prostate cancer. What about other genes? The Lynch syndrome genes that are associated with hereditary colon cancer, also associated with a higher incidence of prostate cancer and early onset of disease. There's also a prostate-specific gene, HOXB13, that's been associated with a higher risk of prostate cancer and early onset of the disease. So I'm talking about factors now that we can test for that are associated with a higher incidence of disease that put one at risk. And so these are the kind of patients, subjects who would be candidates for earlier detection of disease as well. How do we diagnose prostate cancer? The main backbone, the main workhorse of our detection strategy is the blood test, prostate-specific antigen. So this is a protein produced by normal prostate cancer cells, normal prostate cells, and prostate cancer. So it is not specific for cancer, but it is specific for prostate. Historically, we thought that everybody that had a PSA under 4, you were safe, you didn't have prostate cancer. We now know that PSA is not a perfect test in that men under 4 can have prostate cancer. Alternatively, we also know that it's not a perfect test, and just because you have a PSA over 4 doesn't mean you do have cancer, because things like inflammation, size of the prostate, they can make your PSA go up as well. So one of the important things to remember is to get a PSA earlier in life, find out what your baseline is, know what it is, and follow it over time. That really would be helpful. The other thing that we use, not as frequently now, is the rectal exam. That's that glove finger. You can detect prostate cancers that are at the posterior part of the prostate, but you can't detect them when they're anteriorly located. And the other thing is that by the time the cancer grows enough to be felt, it's usually larger and not as curable. So the way we tend to use rectal exam now is we tend to use it as a secondary test. In other words, for the primary screening, it's PSA. For those who have an abnormal PSA, we'll then offer the rectal exam. So it's more of an optional test. You occasionally will find some men who have a normal PSA and an abnormal rectal exam, so that's why it's still worth doing. Now, how do we diagnose it? We got to have a tissue diagnosis to prove that there's actually cancer there. So we have to stick a needle in the prostate. This is often done under what we call transrectal ultrasound guidance. A probe will be placed in the rectum. You can image the prostate and then use a needle to aim the needle to the area you want to go to. Nowadays, though, MRI has really revolutionized our ability to diagnose prostate cancer. Really picks up the internal architecture of the prostate really well. You can see a nice picture here of a dark spot in the prostate. This is a MRI. Oh, sorry, let me go backwards. Did I get there? No, I didn't get there. Let me go the other way. There we go. And MRI not only allows us to see it, but if we can see it, we can target it. So now you might get a biopsy called an MRI fusion guided biopsy. We can talk a little bit more about that, but it allows us to diagnose higher grade cancers more specifically because we're really hitting the target. Now, how does prostate cancer screening, is there data that would really support this at the population level? probably about 4 studies out there. This is one of the ones that's more convincing than others. Some have been more equivocal for a variety of reasons, but this is a study from Sweden. And what they did is they invited 10,000 men to get a PSA and 10,000 men to just be followed. So you were randomized to the screening group or the control group. You got your PSA every 2 years, and you had a biopsy or further evaluation if your PSA was above 3. In the control group, no screening was offered. And what you see in the red line are the screened populations. You see more cancers were diagnosed because you were doing screening. That's not surprising. The real question is, did this translate to decreased mortality? And the answer is yes. In the red line, you can see that there is a lower risk of dying if you had a screen-detected cancer versus the control group. The relative reduction was about 29%. So this is probably one of the best studies for the evidence of the effect of screening on prostate cancer mortality. Now, the big issue with all of these studies is that there were very few black men in any of these studies. So we don't really know with gold standard evidence whether prostate cancer mortality is decreased by early detection in black men using this gold standard. Now, there's a lot of common sense evidence out there that would suggest that's the case. If you look at prostate cancer mortality in the PSA era, we see that prostate cancer mortality decreased about 4.2% year over year in black men, and actually decreased to a higher rate than it did in Caucasians. So PSA certainly has had an effect. Furthermore, when you look at contemporary staging data and survival data, what you see is that disparity in stage at presentation has virtually been eliminated now. You see black men in the blue, Caucasian in the green. You see stage for stage very similar. And you also see very similar 5-year survival. So there's no doubt that PSA has certainly had an effect. Now, there's also a problem with respect to the potential downside of screening. Screening is not perfect. PSA is not a perfect test. What does that mean? There are some false positives. I mean, you can have an elevation in PSA, and it wasn't because of cancer. It was because of something else. But that may have led to a biopsy, which may have led to a complication, something like that. There's also this thing that happens in a screening population. Many of the cancers that are diagnosed are low-grade, low-volume cancers that may never have been discovered. They may never have caused a problem. And the third thing that happens is if you treat a lot of those cancers, which we were really doing earlier, you cause a lot of problems: erectile dysfunction, urinary and bowel problems, things like that. So there were harms associated with screening. So when you looked at an organization like the Preventive Services Task Force that was charged to making screening recommendations for populations, they began to look at this data early on and say, whoa, there are a lot of harms here. We're not sure about the benefit. I don't think we should be doing this. So they gave it a grade D recommendation. What happened after that? Prostate cancer testing done by primary care providers who do virtually all of it really plummeted. And you could see it going down here. And then for black men in the blue, it really went down. Now, what happened with respect to prostate cancer incidence after that? When we were doing the screening, prostate cancer incidence went down, and it decreased dramatically after the task force recommendation, but then began to tick up again. But what we saw in this increase was really startling. We didn't see a real increase in localized prostate cancer detection because of this decreased PSA testing. We saw an increase in metastatic disease. And so we saw, when we stopped screening, the incidence of metastatic disease went up, the exact opposite of what we would have wanted to do. And we saw that the beneficial effect on mortality began to plateau out. So, the urologic community and others who treat prostate cancer were challenged. How can you make early detection better? The goal was now to find and diagnose more clinically significant cancers, to limit the morbidity of false positive tests, and to limit the morbidity of treatment. And a multi-pronged approach to research has helped to really facilitate this. We have a lot of new markers out there. So now, just because you have an elevated PSA, the first thing isn't biopsy anymore. It's get one of these other tests or get an MRI and see if it really suggests you have a significant cancer before you get the biopsy. So MRI has been very, very important in not only deciding who's going to get a biopsy, but the actual quality of the biopsy that's going to be done. We're using newer biopsy technologies that I won't go into here. The other important thing, though, is that we really expanded the concept of active surveillance. In other words, following these low-grade, low biologic cancers and not offering immediate treatment to everybody to decrease the harms. And what we've seen over time is that if you look at a Caucasian population, about 50% of the men with these low-grade cancers avoided treatment at 10 years. The number's lower for black men, about 40% who can avoid treatment at 10 years. Occasionally, though, cancer will grow and may do things that are unpredictable. And that's why you have to strictly follow patients. You have to follow them with MRI, PSA, repeat exams, and there really has to be a contract between the physician and the patient. We're going to watch you, but if it does grow, we can still treat you and treat you effectively. So the last thing I want to share with you is that if you look at the guidelines as they exist now across international groups, there is consensus on some things. One, that there should be a discussion between patient and physician about the benefits and utility of PSA testing. They vary by a lot of different things. They vary by the age to start, the age to stop, the trigger PSA level to intervene at, the frequency of the intervention, and only two mention specifically the concept of high-risk populations like black men. So I'm proud to say that this year, the Prostate Cancer Foundation finally took the bull by the horns, and they convened a multidisciplinary panel, and I was very proud to be a part of this panel of urologists, medical oncologists, radiation oncologists, patients, and primary care physicians to comprehensively review the literature that was available. We couldn't wait for a national screening study to be done. We had to use what existing data was available. And the goal was to determine the potential utility for prostate cancer screening in black men and to develop practical guidelines, messaging that could be used by primary care providers and others that was not confusing and very straightforward, but was evidence-based. And so this was based on the answers to 6 specific questions. And so this was just published this year. And the first question was, should black men be screened for prostate cancer? The answer was a resounding yes. Black men are at higher risk, and the benefits of screening generally outweigh the risk. The second one is, how should they be screened? PSA should be the frontline study. DRE would be optional. The third question says, what information should black men obtain to make an informed decision about PSA testing? So we recognize that PSA testing is certainly personal, but they should speak to their primary care physicians, take into consideration health status, family history, genetics, other things to make this decision. At what age should black men obtain their first PSA? Well, we were very aware of this early onset data, so we say that a baseline study should be done somewhere between 40 and 45, and then the interval should depend on, again, family history, health status, what you know about the patient. At what age should prostate cancer screening stop? For men who are undergoing screening, who are over the age of 75, that is where you really need to have a talk with your physician about whether the risk-benefit ratio is still contributing or still continuing at that time. And finally, how should family history and genetic risk be considered in the equation? Black men are already at higher risk, so if they do have a strong family history, or a genetic abnormality in their families, this would then suggest they should certainly begin by age 40. So I'm going to conclude right there and just give you a couple of thoughts about prostate cancer screening and what you should do. One, I think black men should have these conversations with their families. Find out about health conditions in your family, prostate, other health conditions that are important. Ask your physician about PSA testing. We now have a published guideline out there that they can refer to, okay? Record your PSA number in your phone. Better yet, get access to your own medical records. Most companies now, or most medical institutions, have a portal. You can see your own records. So get access to those records and be in control of your own destiny with respect to that. And if your PSA is elevated or you have prostate-related symptoms, see a urologist. Thank you very much.
Thank you, Dr. Pettaway, for that very exhaustive and very thorough presentation. I have to give it to you, Doc. You are the most non-threatening deliverer of prostate news. Thank you so much for all that you do. Can we give Dr. Pettaway a round of applause? Our next speaker is Dr. Portia Johnson Williams. She is a graduate of the University of North Carolina at Chapel Hill and earned her Doctor of Pharmacy from Howard University College of Pharmacy in Washington, D.C. Double certified in pharmacogenomics, Portia serves as the strategic advisor for various molecular tumor board services and precision medicine development. Furthermore, Portia oversees and contributes to many initiatives, including a health system-wide precision oncology program, the curation and delivery of educational material and presentations to all disciplines, as well as serves as an independent consultant for medical oncology and pharmacogenomics. Please give a warm round of applause to Dr. Portia Johnson Williams.
All right, thank you so much for having me today. I'm so grateful for Veronica, also Rodney, just for having me here. Just very long history with TSU, starting from pharmacy school and you know, my Howard University days. So just very grateful to be here. Prostate cancer is very near and dear to my heart. My father is actually a 2-time prostate cancer survivor, and so I have been through this journey with him as a advocate, as a caregiver, and just really being able to be with him through the journey, which I feel like has made me an even more compassionate pharmacist and practitioner. Here are my disclosures. And just kind of starting with where we are and how we really got here. So there was a precision medicine initiative that was established by then President Obama and led by Vice President Joe Biden in 2015. It's since been renamed the All of Us Research Program, and we'll kind of go into that as far as really being inclusive of minority populations or underrepresented populations. Fast forwarding to the 21st Century Cures Act, and actually authorized $1.8 billion in funding towards the initiation and advancement, which is known as the Cancer Moonshot. That was over 7 years, but I will tell you that we are still ongoing with the Cancer Moonshot even today. And abundant funding was allocated to the National Cancer Institute to really upscale those efforts to further this initiative. This is kind of a picture that I like to show my patients, my residents, my fellows, just to really understand the principles of precision medicine. So if you look at the picture to the left, you see 2 individuals with the same diagnosis receiving the same treatment, right? The blue and the green bag. However, they don't respond the same. And when you move to the picture to the right, you really understand why they don't respond the same. We are not genetically the same, therefore we do not expect to respond to treatment the same. And so that's why it's really important to have genetics and genomics to really inform your treatment decisions going forward. Just kind of going further into this, you know, I'm very a visual learner and teacher, and so looking at the principles of precision medicine or personalized cancer therapy, moving from the left to the right, you see everyone is a gray blob, meaning that everyone is a one-size-fits-all, and we know that the #1 drug rule is never take someone else's medication. right? That is the #1 rule. And so when you're really looking at precision medicine, we're able to really stratify which patients are predictive to therapies, which patients will not respond to therapies, which patients will have an adverse event to these therapies, and then even a prognostic marker as well, right? Which patients, based off of these tumor markers or the genetics, tend to do better or worse or are predictive of different cancer types. So I often get the question of what's the difference between genetics and genomics, and sometimes people use them interchangeably, but just to kind of hone in on this, genetics is the study of individual genes and inheritance, right? Something that your mom and dad gave you from birth will never ever change. I'm really looking at germline genetic testing. These are terms that you might hear as well. Again, looking at a person's genetic makeup from birth, and it can be formed in patients that with or without cancer. So I myself have had germline genetic testing, and I do not have a cancer diagnosis. Then you move into genomics, is really more of a comprehensive term. It's looking at the study of multiple gene functions. When we're talking about our DNA, that is your genome, and really interpreting that based off of tumor markers. And so you might hear somatic, right? Somatic meaning that if a person has cancer, you're taking a snippet of that tumor sample to really inform the treatment decisions going on. And I really say this wholeheartedly, that genetics and genomics is the ultimate playbook for your therapy, for your health. How can we really apply these in cancer care? We know that genetics and genomics, you saw the precision medicine initiatives, it's really revolutionized cancer care by enabling precision medicine approaches. We know with germline genetic testing, we can really identify inherited gene mutations that increase cancer risk, right? So for instance, for prostate cancer, BRCA1, BRCA2. We can even encourage proactive preventive measures, as Dr. Pettaway was saying, as far as PSA screenings, really being active and monitoring those. For a breast cancer patient, right, mammograms, increasing screenings and just being very preventive in that sense. And then, of course, implications for drug therapy. And so we know that, of course, if a patient maybe, for instance, has a BRCA1 or BRCA2 mutation, they may be more likely to respond to something called a PARP inhibitor. So just really kind of thinking about those and how that implies your treatment therapies. And then genomic tumor markers or profiling really contributes, again, to that comprehensive, informed treatment planning, really identifying those potential therapeutic agents and then how we can move forward as far as decreasing the dose, increasing the dose, or saying we don't recommend that drug at all based off of your markers. Here are some genetic testing recommendations that actually came from the NCCN and ASCO guidelines. And so I kind of wanted to break it down into, more of a layman's terms. And so just kind of thinking when to think about genetic testing. So looking at patient selections. Men with metastatic, meaning that the cancer has spread beyond the prostate. Those that have high risk or very high risk localized disease, meaning the cancer has not spread beyond the walls. And then particular types of identified prostate cancer tissues or histologies. Looking at family history, we talked about family history is so important, and we'll talk about this hopefully on the panel, of just really not keeping that information to yourself. It's so important to inform your loved ones where they came from. And so when you go to these, even your PCP, they ask you, what is your family history? And if you don't know, you can't really inform what your decision for yourself or for your loved one should be. So really talking about that. But if you have a family history of certain cancers, such as breast cancer, prostate cancer, pancreatic cancer, for instance, or genetic conditions, or even known family history of cancer mutations, or risk mutations such as BRCA1 or BRCA2, or even a personal history of male breast cancer is also an indicator. And then, of course, we're looking at heritage. So if you were of Jewish heritage, particularly Ashkenazi Jewish ancestry, that would be when to consider thinking about genetic testing. And then when you get in there, you say, well, what do I discuss, right? And so kind of breaking that down as well, we talked about early screening. For those that have certain gene mutations, really considering starting these PSA tests earlier, especially age 40. That's something we really want to hit on, that marker. Tailored treatments, we talked about genetic tests can really personalize your treatment choices. And then family health, just really identifying family members that might be at risk. So if you know your history, then you're able to impart that on your immediate family members, maybe it be your brother or your father or your sons, your grandsons, to really inform their treatment decisions as well. And it ultimately comes down to a more comprehensive care. So gene panel testing, we know, really helps determine the best treatments, not only for what's on the market, but what's coming on the market as far as clinical trials, right? So if you don't know what mutations you have, oftentimes that informs what clinical trial that you can be on. And so it's really important to have that information. And then for post-treatment testing as well. So you might be on a current therapy, or a targeted therapy is what we kind of call it. And if you are continuing to progress, we might want to see why. So you'll have a repeat test just to see if there's some kind of resistant mechanisms that are going on, and then kind of can circle back and pivot from there. We talked about, PSA, we talked about DRE, but I also want to talk about different methods for germline testing and liquid biopsies that we don't often talk about. And so these are some kind of non-invasive ways to have the germline testing or genetic testing through liquid biopsies. And so starting from the left, we have a buccal or a cheek swab where you simply are performing, it's like a Q-tip, and you're just brushing against the inside of your cheek to really gain those cells. And then we have saliva tests where they will basically send you a tube, and you have certain recommendations of like not brushing your teeth for a certain period of time beforehand, or not eating, and just only drinking water so you don't contaminate that sample. And then collecting that in saliva tissue or saliva test to really inform that decision as well. And then we have plasma or blood draws where a nurse or phlebotomist can come and draw that sample for you and to really inform that treatment as well. We have a couple of social considerations, and I really want to talk about this because especially in clinical practice, I might have patients that say, well, I got this 23andMe, what can you tell me about my tumor? And I want to just kind of emphasize that recreational genetic testing such as 23andMe are not necessarily validated to give you the most information for your treatment planning for your tumor type, right? They may, I know there's some are more advanced now, maybe tell BRCA1, BRCA2, but just knowing that the clinical validity is not always there. And so really looking at more of these lab vendors such as Caris or Myriad, things of that sort that can really tell you what's going on in your body from outwards in. And so then just talking about social determinants of health, I talked about how my father is a 2-time prostate cancer survivor, and it was very important for him to have the best care. And so we actually flew to a premier academic institution. My father is very intelligent, engineer, does financially well for himself, but I thought about it. Neither time when we were there did they ever ask him if he would like genetic testing. My father has lost several siblings before the age of 50 to several different cancer types. So going on that, and at that point in time, he wasn't even 50 yet himself. So based off of the guidelines that we really shared, he should have been offered genetic testing. And it wasn't until the second recurrence, and I actually had 2 little ones, that it was important for me to find out. And I kind of drug him along with me to find out as well. So just really having that advocate, and that's why I really wanted to empower yourselves, because even if you go to these premier institutions and you're thinking that you're getting the best of care, you have to be equipped and empowered to advocate for yourself, because it might not often come from the provider that you seek and trust, okay? So just want to kind of put that out there. And then just talking about inconsistency in racial and ethnicity ancestral categorization. We often identify as Black or African American, but just being mindful of the subpopulations that exist within there, and just different, the admixture, right, that could occur as far as risk populations and things of that sort, and what you might be more prone to, just really thinking about how we can be more inclusive beyond a box, right? You see this checking box, and we know that many of us are beyond, we're more than one of these, and we're not a homogenous race, so just kind of really keeping that in mind, especially as we stratify for research going forward. This is something that I really want to talk about as far as Genetic Information Non-Discrimination Act, or GINA. I'm really talking about your laws and the powers that you all have. This particular act really prohibits medical insurance or employers from discriminating against individuals based off of their genetic information. There are some caveats though, so I do want to be very transparent in that. That the GINA Act does not protect against use of life insurance or long-term disability, so really planning ahead and getting that done beforehand. It does not shield those covered by IHS, VA, federal employees, or U.S. military plans, and it does not apply to all private employers, meaning those that have less than 15 employees. So just really being equipped and knowledgeable about the laws that do protect you, and not being fearful to go ahead and have those informed treatments. I really want to show this. This is basically the demographics of our genomic databases. In the box, I kind of showed what the 2020 U.S. demographics looks like, and this is probably of no surprise to you, but it's heavily populated by those of European ancestry, followed by Hispanic, Black, and then Native American and or Pacific Islander. But moving on to the right, you see the different genomic databases such as the AACR Gini, Pan Cancer TCGA, MSK Impact, and then the University of Michigan. And you can see that these genomic databases are heavily underrepresented by minorities and overrepresented by those that are the majority, being European ancestry. And so essentially, because of what's in the current genomic database, because we're not testing and we're not giving our information to help inform these treatments, you essentially are taking someone else's medication that was not built for you because you were not involved in these clinical trials. And so that's something I really want to emphasize, in knowing that clinical trials are not the last resort. Oftentimes they could be the first discussion to have, and oftentimes they're better than what's currently standard of care. So just really keeping that in mind. And even if this does not affect you, it may help inform those that come after you in generations to come. So with that being said, the FDA has really given a charge to industry. I work for J&J as well as a lung cancer medical science liaison, and this is something that I know for sure that we're definitely implementing, but diversity action plans to improve enrollment of participants for underrepresented populations in clinical studies. Again, we really want to come out to forums like this to really educate those so that you're not afraid to contribute to the data, to the science, and so that we can, again, inform treatments moving forward and to really help those that either ourselves or generations to come. So again, like I said before, you cannot always rely on your providers. We have some really, really good providers, but we also have providers that are very busy, and they may not be able to keep up with everything, and so that's why we have you all to really advocate for yourself and to really talk about these conversations. And so just talking about how genetic testing can really help with prostate cancer, we talked about the personalized treatment, early detection, and just family health in general. And then why talk to your providers? We want to get the right information, right? We don't want to have someone else's drug and expect to have the same result. We're better than that. This is an informed playbook. We really want to make sure that we are getting the best treatment and the right drug for the right patient at the right time based off of precision medicine, discussing the risk and benefits, and then making informed decisions together. We're really talking about shared decision making. And I would really encourage you, don't go to these appointments alone. Take someone with you, because oftentimes you're in shock. It's so much information. You might not be able to recall what happened, but someone with you will be able to be your advocate, your accountability partner. So really keeping your family informed as well. How to start the conversation? Ask, right? You have not because you ask not. So asking these questions, bringing it up, sharing your concerns. If it's a financial concern, bringing that up as well. If it's a concern about childcare or caregiving, as far as being in a clinical trial, have these conversations because there are resources available to really help that. And then staying informed and being proactive about your health, really taking charge and supporting your family. I'll end here. Here's my information for any resources you might need. I'm more than happy to talk to anyone after this conversation, but I'm very thankful for being here, and thank you so much.
Thank you, Dr. Portia. Man, just so much education. Never really realized how much reading and research doctors do. And as I'm sitting there, I said, you know what? Seminary doesn't have anything on medical school. I will never barge into my doctor's office again and try to tell him how to do his job. Thank you. Thank you so much. Maybe give another round of applause for Dr. Portia. Are you all enjoying yourself? Just raise your hand if you're enjoying yourself. That's great. That's great. We are now going to transition into our panel, our healthcare provider panel discussion. We're going to be bringing our panelists on, but we're going to we're going to allow them to come on stage after each biography is read, and then allow for the panel discussion to begin. We're going to read the biographies of the first two panelists, and then the final three panelists. We're just going to call them up because we've already read their bios, okay? Dr. Hunter, we are proud to bring Dr. Hunter, Dr. Rodney Hunter. Dr. Hunter is a clinical associate professor and a clinical pharmacy specialist in breast medical oncology. He has served as the program director of the TSU, Texas Southern University Breast Cancer Screening and Prevention Center. He actively works with the Center for Biomedical and Minority Health Research at Texas Southern University on research projects and community outreach initiatives. He is also a clinical assistant professor in the Division of Internal Medicine, Department of Oncology at the University of Texas Health McGovern Medical School. He obtained his Doctor of Pharmacy degree from Texas Southern University in 2007. He then went on to complete an oncology fellowship at the University of Texas MD Anderson Cancer Center. Please welcome Dr. Rodney Hunter. Our next panelist is Dr. Rafi Tal-Yukter. Okay, yes. Dr. Rafi Tal-Uchter is an associate professor of medicine at Baylor College of Medicine at the Dan L. Duncan Cancer Center. He is a genitourinary medical oncologist with a clinical and research focus on prostate, bladder, kidney, and testicular cancers. Dr. Tal-Uchter is board certified in internal medicine and medical oncology. He is a native Houstonian who went to medical school at the University of Texas, Long School of Medicine in San Antonio, and completed his internal medicine residency at Baylor College of Medicine. Dr. Tal-Uchter then completed his fellowship in medical oncology and hematology at the University of Washington Fred Hutch Cancer Center, where he served as a chief fellow during the second year of his training. Please welcome Dr. Rafi Tal-Uchter. We are now going to call the final three panelists to come up. Of course, we're going to ask that Dr. Curtis Pettaway, MD, come back up. Yes. We're going to also ask that Dr. Portia Johnson Williams comes back up as well. That's it. Okay. Well, we'll transition into our panel, and we'll go into it from there.
Thank you very much. Very excited to be here. Dr. Edgeworley, thank you for your continuing to invite me. I really love this program. I love this opportunity, and I'm excited to speak with these great panelists this morning. So let's go ahead and get started. We have a lot of things to talk about in a short period of time to do so. So I'm going to start with you, Dr. Johnson, and I want you to build on some of the things that you talked about in your presentation in reference to what is the difference between family history and genetics and genomics, because I think that's something that the crowd is definitely a great learning tool.
Yeah, absolutely. Family history are shared diseases or genetic conditions or even genetic predispositions that go from generation to generation, such as a family history of breast cancer or cardiovascular disease, right, or immune disorders. And then as far as genetics versus genomics, that would be genetics is more granular. That is something that you were always born with, inherited from your mom and your dad, and that particularly affects one gene, right, such as BRCA1 or BRCA2, and then when you go into genomics, it's more of a comprehensive panel looking at environmental factors, lifestyle factors, even what you eat, and then even your genome as far as your DNA, and that really takes account to what your tumor looks like. And so again, that would be like the ultimate playbook of what's going on in your body, and then be able to present that outward to your physician.
Outstanding. I want to move to you, Dr. Pettaway, and I want to see if you could give the audience any tips in reference to reporting like family history of prostate cancer, and when should they talk to their family members about their history of prostate cancer?
That's a good question. I think that there are natural gathering places, and I think that as men, we certainly want to lead the family. So certainly around the dinner table is a great time to do it. At the barber shop, community centers, natural gatherings, church, be open and honest and transparent, because you want to help others. So things that you know that are important, or information that you want to begin gathering to lead the family. You want to ask your uncles and grandfathers, hey, what did Uncle Joe die of? Those kinds of things. So that you'll really be informed about this, and you can kind of construct a little family tree that will be very helpful for you when you visit your own doctor, or to be a resource to other family members about the things that are going on in the family. So I would just urge you to really get after it.
Excellent. I think I want to build on that, because you mentioned the church, you mentioned the dinner table, family gathering. So Dr. Johnson, do you have any tips like for family members on how they can obtain this like sensitive like health information like in today's times? Because of course, like there are things like HIPAA that maybe protect someone from getting it outside of verbally talking to their family member about it.
Yeah, absolutely. I feel like as as a culture ourselves, we really have to get away from the thought of like, don't air your dirty laundry, right? You might have individuals that are going through cancer and you may never know until it's far too late. And so just having those open-ended conversations of like, hey, like let's just, as Dr. Petaway was saying, around the kitchen table or a family reunion is a great time of just having those conversations. What's going on in our family? What did such and such die from? What is my history? Even ancestral history, right? Knowing that is very important, especially as far as clinical trials and really to help break away from those one-size-fits-all, check the box, I am this. We are a multitude of things. Active listening, oftentimes I think people may tell you in a roundabout way, especially our elders, right, may not come out and be so forthcoming for what they actually are going through. And then just asking those open-ended questions as far as, don't just say, do we have prostate cancer history? Like, what is our history far and beyond? And I think just having compassion is really important in respecting privacy. So if someone does tell you something in privacy, making sure that you are sensitive to that information and also culturally sensitive to what those implications may be.
Outstanding. Excellent, excellent. Okay, Dr. Taylor, I have 2 questions that I'm going to ask you like back to back, or actually about 3 or 4. I'm going to break them up, but I got a lot of things I want to talk to you about. I see you in a lot of Zoom meetings. Programs, but I've never seen you in person, so it's great. It's great to meet you. It's great to meet you. So I want to start out with, could you explain to the audience what are urologic cancers?
Right. Yeah, that's an excellent question. So when we talk about genitourinary cancers, it's kind of a conglomeration of different types of cancers, prostate cancer being one of them, which is the focus of today. But other GU cancers include bladder cancer, kidney cancer, testicular cancer, anything in that urinary tract, so anything starting from the kidneys, down to the bladder, the urethra, prostate, testicle, penis. So there's many different cancers that kind of group in together.
Excellent. So I want to build on that. So as you talk about this host of different cancers in this particular system, or is prostate cancer the only cancer that African American men should be essentially weary of or worry about?
Unfortunately, that's not the case. We know we have a lot of data now that African American men have higher risk of having prostate cancer, but we also know in bladder and kidney cancer as well too, African Americans tend to do worse. My research primarily focuses on bladder cancer, and what we've seen is in African American, both men and women, African Americans are diagnosed at a younger age with bladder cancer. When they get bladder cancer, they're diagnosed at a later stage, meaning more advanced stage. And when we treat them with either chemotherapy, surgery, radiation, they do worse.
Great information for the audience as we try to continue to educate the community on all of these types of cancers where they may be at risk of. So now I want to build on I referenced our Zoom calls. So
many Zoom calls.
In reference to our Zoom calls and the NCI NIH funded CURE study that we got funded for with Dr. Adjewale's leadership, can you talk a little bit about your pilot project that you have on that grant?
Yeah, so first of all, I want to say thank you for including me in this project, very important project. So we have a collaboration with TSU and Baylor College of Medicine, and the main goal of this pilot project is to answer this fundamental question: why do African Americans do worse with bladder cancer? Mm-hmm. And just like Dr. Petaway mentioned in his talk about prostate cancer, it's multifactorial, right? Access to care definitely being one of them, but we also know, and we have preliminary data, that there is a biologic component as well too. We know that in bladder cancer, again, I'm sorry, we're talking about bladder cancer, I know this is a prostate cancer forum, where you live, what type of jobs you do, your access to care, influences your outcomes and affects your chance of getting bladder cancer. So essentially this study is essentially to study that, looking at the neighborhood level, looking at people, doing surveys and asking people where they lived, what type of environmental exposures they had, smoking history, and then doing testing on their tissue to see if we can find some correlation between these exposures on a neighborhood level and changes in the tissue as well as outcomes as well. This is a small study, but I think this is a first step, and we hope, with positive results, we can expand this with larger, with more funding and hopefully expand this to a national level and not just here in
Excellent.
Houston.
We are building. Okay, yeah. We're building.
Yeah, very nice, very nice.
So, Dr. Pettaway, with your question, I'm hoping that I invited some family members to this event today. They're not local, so hopefully they've joined online. We had a recent diagnosis in my actual family of prostate cancer just earlier this week. I got the call. I get the calls all the time, but unfortunately I got the call this week. But thankfully, we have this event to really educate them on what we're expecting moving forward. And I say all that to say, when you think about the advancements of the treatment of prostate cancer, what are you most excited about?
There's a lot that I'm excited about. When we look at from the diagnostic side, I would say that I'm really excited about the fact that we can really begin to stratify cancers into those who may be clinically less indolent, and we don't necessarily have to treat them. We can follow them. They can maintain their quality of life, maintain their jobs, everything that's good about that. But those that really need treatment, we can really move forward and treat them aggressively. When we look at the later stage of disease, and I'll certainly refer to Dr. Tolutkar here, what we see in men with disease that's already spread beyond the prostate cancer. Let me give you an example. When I was a resident, basically, when you were diagnosed with metastatic prostate cancer, that means you got androgen deprivation. That lasted for about 18 months to 2 years. Then pretty much within the next year, you're pretty much going to die of prostate cancer. So it's about 3 years. Nowadays, we are offering men doublet therapy and even triplet therapy beyond just the first generation anti-androgen types of agents. And we're really seeing prolonged survivals and men being able to enjoy their life and their families for a longer amount of time. We certainly can't say we can cure men, but we can allow you to live longer. And Dr. Tolutkar might want to amplify on that a little bit.
Yeah, absolutely. And I think we now have data showing that, back in the day, right, it was androgen deprivation, so hormone therapy, and then that's it. Now, we have data that if you have stage 4 prostate cancer, the average life expectancy is about 4 years, 4 to 5 years, and that's increasing, right? Again, we still have a long way to go. We want to improve that even more, but compared to 10 years ago, that's a huge improvement.
Yeah, before, it was like 2-3 years max, So we're definitely making some advancements.
Yeah, now we're 4 or 5 years, and kind of, I feel like every year we're coming up with new therapies. We have hormone therapy, we have targeted therapies, we're now doing immunotherapy and cell gene therapy in prostate cancer. So there's a lot of treatments coming along. And I think one of the important things, we're learning is, and as Dr. Johnson mentioned in her talk, not all prostate cancer is the same. Not everyone's the same, right? Personalizing care, making sure who's going to benefit from what treatment. Do we need to intensify treatment for someone? Can we wait to hold off on intensifying? Right. So there's a lot of exciting things going on right now in prostate cancer.
And this is why it's so important to really take charge of your medical care. Mm-hmm. If your physician doesn't bring up the issue of genetics, molecular profiling of tumors, things like this. These are things that you need to talk to them about. Or, is there something? Is there a clinical trial that I might be a candidate for? Is there any kind of new testing that could be done that might shed light on how my treatment might be better for me? Mm-hmm. Those kinds of questions will begin to spark ideas in his head. Yeah, maybe I better profile this tumor or something like that.
And then this is, sorry, just to add to that, if you have a friend or loved one that's diagnosed, but not just prostate cancer, any type of cancer, make sure there's someone there with them in that visit, because that initial visit is very hard, right? And very emotional. And if there's someone there, they can help you emotionally, but also ask questions that you're not thinking about, So what I do in my practice is, if someone comes by themselves, I ask them, hey, can we call someone? Call someone. Or there was a time where a patient was like, can we reschedule till next week because my daughter's coming into town? So I think that support is very important, not just emotionally, but also helping ask these questions. Do I need genetic testing? Is your clinical trial that will be beneficial for me?
I'm going to swing the wagon back around to that in just a minute, but we're going to go over to Dr. Johnson because y'all mentioned something that I think is very important. In my clinical practice, this is a frequent conversation that's had, and it's about genetic testing and the coverage. It's about how do insurances play a role in a patient being able to get genetic testing. So can we start there with you, Dr. Johnson?
Yeah, absolutely. I mean, we have such a comprehensive multidisciplinary team, and they really have like patient navigators, and even, your nurses or your pharmacists can take that information back to the providers to really have those conversations, but you have got to be honest. If you have concerns as far as financial concerns, they have something where they can pre-certify and see what the cost may be beforehand. They have grant funding, foundational funding. For instance, when my father and I got germline testing together, they told me my out-of-pocket might be $100, with insurance, and ended up being nothing at all. And so just being very honest about that and having those conversations. And again, I want to emphasize, you have not because you ask not. So don't be afraid of what people might think about you or how this might come off, or you don't want someone to whatever. Just be honest, because at the end of the day, your health, your children's health, your grandchildren's health are at the end of this visit. So just being able to have access to that is so important. And again, like I said, they have patient education or information forms where you can fill out, maybe what your salary is or something of that sort, or what kind of support. But even from a clinical trial standpoint, do you need gas cards? Do you need childcare support? Do you need someone to come to your house? Do you need telehealth visits? If you have any kind of barrier that you feel like it's going to preclude you from being in the studies or receiving the treatment or the care that you need, having those conversations, finding somebody on that multidisciplinary team that you trust, they can relay the information for you.
So I want to build on that. So you mentioned that you had a out-of-pocket expense of possibly $100, but when it came to pass, it was actually zero. If a patient has no insurance, like what do you think the typical cost that we're seeing in today's market of a genetic test is?
Yeah, it depends on the size of the panel. So you have some panels that are what they call hotspot panels, where they're maybe only testing for 1 or 2 genes, versus something that's super comprehensive that can go over to several thousands of genes that they're testing. And that ranges from anywhere from maybe $100 to a couple of $1,000, right? But being aware that it's better to have than not need as far as the level of information than to need and not have when it comes to as far as treatment planning. You're having to move fast, right, or being in these clinical trials fast. Understanding as well as far as genetic or genomic testing, it's about a 2-week turnaround time sometimes, right? And so you're kind of waiting because you want to have the most precise care. So you need that playbook, right, that information that's going on in your genomic database to really inform those treatment decisions. But I will say, I have seen up to $2,000 or so, but really taking that information when you get that pre-certified and taking it back to the company. A lot of these companies, these lab vendors, will absorb that cost. Yeah. And so just being mindful of, like, you don't have to pay that. Even though you may see that bill, you don't have to pay that. They do have financial assistance. They do have payer programs. They do have foundational or grant support that will cover that all together. So don't be afraid to do that. And when you do get your results, sharing that with your family, because sometimes, and having a genetic counselor go through that is so important too, because you don't want to sit there and try to interpret it yourself. You want to have someone really talk to you about what does this mean for you or for your family members, and then what they call a cascade testing, meaning that if you have something that is of concern, or maybe a prognostic marker or predictive marker, then your loved ones, your immediate family members, your children, your offspring will also get tested as well to see where they can go from that as far as a preventative measure.
Great. That's the information I wanted to bring out there to the audience. Dr. Luke there, going back to you, now I'm talking about artificial intelligence. Okay, so we had a lot of images there when we were talking about the PSA testing and the prostate screening. Does artificial intelligence come into play when you're looking at prostate screening? Is there data there?
Yeah, so I think artificial intelligence is the hot topic right now, right? The buzzword. In people that have prostate cancer, localized prostate cancer, we're actually using artificial intelligence models to help predict treatment. There's a model called Artera AI, where if you're getting radiation, it can help predict how much hormone treatment you'll need. So in someone that has prostate cancer, we're already using AI to help guide our treatment. The question is, can we use AI before that in the screening? So we still have some work to do. There's ongoing studies. They recently just published a large study from UCLA where they took 10,000 images and they essentially asked radiologist 10,000 images of MRI of a prostate of patients who may have prostate cancer, and they asked a radiologist to draw out the contour, to guess where the prostate cancer could be, and then they had the AI program do it, and the AI program was much more accurate. So again, there's promise there, and hopefully in the future we can use AI to help, identify false positives, hopefully prevent unnecessary biopsies, or maybe identify patients that have low PSAs that may need a biopsy.
Exactly. Yeah.
So now I'm bringing the wagon back around to treatments, as we were talking about some advancements in treatments, and we were talking about self-advocacy. So I wanted, and this could be a kind of multifactorial question where all of the panel can maybe chime in. I think we have history on treatment, we have family members, we have all kinds of experience I'm sitting up here with. So my question is about the difference from a patient's perspective between androgen deprivation therapy, which I'll mention, which is the hormonal therapy, a patient getting a surgical management of the prostate cancer with a prostatectomy, or possibly getting radiation. So I'm gonna, I can start from the top with all of the panelists as far as chiming in as we wind down our time.
Well, maybe I'll start off. So it all starts with evaluating the patient and defining their disease characteristics and the extent of disease. If using our best available tools, we feel that the disease is localized, then we want to offer a local therapy. And that local therapy could be surgery, it could be radiation. Down the line, we might be talking about various focal therapies using high-intensity focused ultrasound or cold energy like cryotherapy or laser energy. So these things are kind of on the forefront. But when something is localized to the best of our ability, and this is a moving target nowadays with new scanning strategies and things like that, but when something is localized, then we're talking about a localized treatment strategy which theoretically could eradicate the disease and cure the patient. When we talk about androgen deprivation, we have to realize that prostate cancer is what we call heterogeneous. Imagine a whole crowd of people. Everybody doesn't look the same, right? So some of those cells are going to be sensitive to the androgen deprivation. Some will be sensitive to a varying degree. In other words, some of those cancer cells may be killed by the hormonal therapy. Others may stop growing for a little while, but then begin to grow later, and other ones don't even care. So androgen deprivation therapy in and of itself is not a curative strategy, but it helps us by cytoreducing the cancer, by decreasing blood vessel formation around the cancer, but in and of itself, it is not curative. So often you're going to use it as an adjunct for a therapy when you don't have a curative local option where, let's say, the cancer is now spread to the lymph nodes, spread to bone or other sites. I'll let Dr. Talukar take over from there.
Yeah, so most of the patients I see have advanced cancer, meaning they either had localized cancer first, got surgery or radiation, and then progressed, or they just were diagnosed with advanced disease to begin with. And in that setting, we focus on systemic treatment. At that point, surgery or radiation may not be an option or a priority. At that point, we want to make sure we attack the cancer that's, wherever it is. And the way we do that is through systemic treatment. One of the modalities is this androgen deprivation treatment. But, we know that alone is not enough. And now we have other treatment options available, other ways to block, testosterone, which I like to say, I like to eat sugar and fat and get bigger. Prostate cancer uses testosterone to grow and get bigger. At least most of them. So we use multimodality, and sometimes we use chemotherapy up front with it as well too. So what I'm trying to say is everyone's different. We're not textbooks. Everyone has different priorities. Everyone has a different cancer. Everyone has different comorbidities that that help guide us what is the best option in terms of treatment when someone has prostate cancer that's already advanced and left the prostate and gone to the lymph nodes or other organs.
Yeah, I want to kind of piggyback off of that. Something you said kind of sparked something. It's kind of well known that Black men have higher testosterone levels, right? We know that this is a testosterone or hormone-driven cancer oftentimes. And the patients that I would see when they came to the medical oncology side of things is it was metastatic or, far progressed. And so just really emphasizing, I don't know if you have a wife or a daughter or a spouse or a loved one that can push you to go be seen. I think Dr. Petaway mentioned the symptoms of urinary frequency or maybe you have urinary obstruction or there's some kind of pain. Don't just take that for granted, really going to see someone about that earlier on, because the more that you wait, cancers like misbehaving cells, they are just running rampant and getting bigger and bigger to the point where by the time you do have to go see someone, it's so far gone and you're trying to reel it back in. And sometimes it's not always that way. It's not always curative. So just really keeping that in mind, getting your regular checkups, not being afraid to go to the doctor if something's wrong, telling your wife, telling someone so that they can push you to go be seen, I think is very, very important.
Yep. And in my own practice, just that anecdotally, unfortunately, most of the African American men I see come in with stage 4 cancer. They weren't screened, they waited too long, so this is something that needs to change.
This is why we're here. This is why we're here, because all of the individuals out there, they're assimilating this information, they're gathering this information, they're gonna bring it back to their sons, they're gonna bring it back to their fathers. There's women that are out here, they're gonna bring it back to their loved ones, they're gonna bring back to their immediate family members, and we're gonna ultimately be impacting this community. And now I want Dr. Adjewale to hire me full time as the moderator, so I can get to you. Okay, so I think we have a little bit of time to possibly ask a question or two if the audience actually wants to ask a question. One question. She said not two. One question. Yes, sir.
Dr. Petaway, I was wondering, do you think that the Preventive Services Task Force is going to take the recommendation or consider the recommendations of the Prostate Cancer Foundation surveys with respect to pre-screening age requirements?
So I want to make a little distinction. So the Preventive Services Task Force, what they're charged to do is look at the existing evidence and make recommendations. They're looking at the hierarchy of evidence. And when we talk about hierarchy of evidence, we're talking about levels 1 through 5. And so the highest level is a randomized controlled trial. They don't have a randomized controlled trial, but what they will do is look at the risk to benefit ratio. And if they see that we are now decreasing the morbidity of prostate cancer treatment by using active surveillance, we're using MRI and other adjunctive tests to decrease false positives. Just like they did in 2017, they changed their recommendation. They say, okay, now we believe that there is some benefit and you've lowered the risks, so we believe that prostate cancer detection is reasonable for well-informed men as long as you discuss the risks and the benefits. And that's kind of where we're at right now. So unless we get a randomized controlled trial in black men or something like that, and some of these are in the offing, not necessarily for black men in general, but new screening trials are in the offing right now that could broaden the recommendation. And I think that's really what we need. I think that the potential for really honing early detection to make it really sensitive and specific is there. And I think AI could definitely help us here. One of my fellows sitting back there, Dr. Matt Smith, he's really interested in this area of really trying to hone early detection in black men. He's going to be working in the community. I've got Dr. Ajiwole. I told her I was going to introduce him to him. But yeah, so we're really excited about having Matt on board and what he's going to bring to the equation, specifically right here in Houston and Harris County.
Excellent. And I think that's going to conclude our panel discussions. I thank the panelists for letting me moderate, and y'all did an excellent job.
Thank you. Thank you. Thank you, brother. Thank you so much. I appreciate you all. You can have your seats. My name is Nkechi Ogbo, and I have the pleasure and honor to work under Dr. Ajiwole's leadership here at Texas Southern University. And next, I have the pleasure to present our TSU, a performance by our TSU's debate team. Yes, 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 yes. So stay tuned and be encouraged and be be blessed. Amen. We're in church, so I mean.
Cancer is still a rare condition, and no two patients are ever the same.
Each person will react differently to the diagnosis and treatment, so there is no set formula for how others should respond.
However, with any challenge, there are certain things that can help.
The Texas Southern University debate team is proud to make this Reader's Theater's presentation, scripted especially for this occasion by head coach, Dr. Gloria Batiste Roberts, entitled
A Brighter Tomorrow.
Prostate cancer is the most common cancer among men in the U.S., according to the CDC.
Prostate cancer is the second leading cause of cancer-related deaths in men.
1 in 8 men will be diagnosed with prostate cancer.
1 in 4 black men will be diagnosed with prostate cancer in their lifetime.
Certain things that help to address the challenges of prostate cancer are
love. Just the knowing that you have people around who love you and care about you can be so empowering and uplift the spirits. Sometimes friends can be afraid of saying the wrong thing and opt to say nothing. However, imagine how you would feel to have your friends disappear when you are diagnosed with cancer.
Care. Taking time with someone or doing something for another is precious. Knowing people care about you can, in itself, feel like a sea of support.
Time. This is one that often does not get recognized, as cancer manipulates the time that a sufferer has. Just giving your time as a friend is a wonderful gift, be it to listen, to do something considerate, or to be available for treatment and tests, are all great ways to show that you care and more importantly, that you are with them on this very challenging journey.
Cancer is so limited, but there are certain things that cancer cannot do.
It cannot cripple love.
It cannot shatter hope.
It cannot corrode faith.
It cannot destroy peace.
It cannot kill friendship.
It cannot suppress memories.
It cannot silence courage.
It cannot invade the soul.
It cannot steal eternal life.
It cannot conquer the spirit.
Elizabeth Kubler-Ross said, "The most beautiful people we have known are those who have known defeat, known suffering, known struggle, known loss, and have found their way out of the depths."
These persons have an appreciation, a sensitivity, and an understanding of life that fills them with compassion, gentleness, and a deep, loving concern.
Many Black men fought for prostate cancer awareness after diagnosis, including
the late actors Sidney Poitier and Harry Belafonte,
General Colin Powell,
and most recently Al Roker, weather anchor on the Today Show, and Dexter King, a son of the legend Martin Luther King Jr.
Up until recently, I was among the thought that prostate cancer poses to our health, says Dennis Morris, who is renowned for his portraits of Bob Marley and the Sex Pistols.
Tony Wong says, "We're calling on Black communities everywhere to bring up the conversation of their health and prostate cancer with dads, brothers, uncles, and friends."
Benjamin Zephaniah says, "It's always been hush, hush. In my community, prostate cancer has always been a bit hush, hush."
Hush, hush, because of the way it affects our private areas. No one really talks about it. Instead of prostate cancer, it is referred to as water problems. David Hayes says, "The fight against prostate cancer is one that we can all win if we stand up to the facts and take action before it's too late."
The problem is that not enough of us talk about the disease.
As a Black man, not only am I more likely to get prostate cancer, I am more likely to get it younger. This disease can be treated if it is caught early. So please don't let your pride get in the way.
If you're Black and over 45, talk to your doctor about prostate cancer. Don't wait for any warning signs. Don't let prostate cancer knock you out.
I am home now from the battlefield.
Wounded, bloodied, and broken.
And the war rages on. Tears run down my cheek and drip off my chin.
The poison of war is still running in my veins.
Clutching my stomach, clouding my mind, burning my soul.
And the war rages on. To survive combat, I must learn when to fight and when to give in.
The delicate dance of when to stand up and when to lie down.
And the war rages on.
The war drums are pounding out their calls.
The war is not over, and you must fight again and again and again.
So I join my brothers back on the battlefield. We are a wall of fierce determination.
We will not be denied the opportunity to take action before it is too late.
And we will never stop trying to find a cure for prostate cancer.
We look for a brighter tomorrow.
We look for a brighter tomorrow.
We look for a brighter tomorrow.
Wow, can we give it up for the TSU debate team one more time? You all did a phenomenal job. Thank you so much. I think I share the sentiments of everyone. I mean, we all feel encouraged and invigorated just listening to that presentation. Thank you so much. May we give them another round of applause, and our panelists another round of applause as well. And so as we just do make a few transitions, a few housekeeping items we want to just take care of. We have a question and answer survey and social media. And so for our on-site attendees, there is a folder that contains a note card for question and answers. Also check out our infographics as well. And you can also complete our survey using our QR code. That QR code is located on the screen to my left or my right, and you can zoom in on that QR code and take the survey. Again, for our online attendees, we ask that you please post your questions in the Q&A box. There is a survey that is posted as well. And also, for some of our attendees as well, you will receive a free 2.0 CHW continuing education hours. Let's give a round of applause for that. Somebody's getting their continuing education. You must complete the survey and evaluation to receive credit. Scan the QR code for links as well. Now, we are streaming live on Facebook and YouTube, so we invite everyone to share. You know, we are living in a smartphone world, and we ask that you stay connected by following us on social media and subscribe to our mailing list and our text message platform. You can also text TSUCEC to 855-264-9031, or you can connect either Facebook, Instagram, Twitter, now known as X, and the other social platform I believe is is it LinkedIn? LinkedIn. And you can connect with us at CECT X Southern University U, or CEC Texas Southern, Texas TX Southern, then U. And we'd love to connect with you on social media. Now we're transitioning into our prostate cancer lived experience panel. It is my honor to introduce the moderator. Donnell Cooper has spent over 20 years as a community leader and dedicated to providing educational support and economic opportunities to families and students. Donnell is currently a campus director with HCC, overseeing the educational careers of Houstonians at 5 campuses. As campus director, Donnell directly impacts the lives of thousands of students by providing instructional leadership and implementing curriculum and campus programs. Cooper received his BS in criminal justice with a minor in sociology from Southern University. He also completed his master's in public administration at Texas Southern University, and later his Doctor of Education in Professional Leadership concentration from the University of Houston. Please welcome our moderator, Mr. Donnell Cooper with the African American Male Wellness Agency. Our next panelist is Thomas O. Commenda. I hope I'm saying that right, Commenda. He is a family medicine doctor practicing in Houston, Texas, affiliated with the Michael E. DeBakey VA Medical Center since 2002. He received his medical degree from the University of Nairobi, Kenya, a master's in public health at the University of Texas Houston School of Public Health, and completed his residency at UTMB Galveston. He has been in primary care practice for more than 20 years. Dr. Kamunda has also participated in many medical missions to various destinations, including Honduras, Mexico, Angola, and Kenya with Bethel Global Reach. He is a board medical director at Care for a Child Heart, an NGO dedicated to helping children born with congenital heart conditions get life-saving surgeries in East Africa. Please welcome Dr. Thomas Kamunda as well to our panel. Our next panelist is Dwayne Charleston. He has been a writer his entire life. Charleston served as the first black judge in the history of Waller County and was a leader in voting right marches for many years in that county. Diagnosed with stage 4 prostate cancer in 2009, he has never been in remission, yet continues to overcome this insidious disease 15 years later. Yeah, amen, amen. That, yes, sir. Yes, sir. Yes, sir. Yes, sir. Charleston has endured 4 surgeries, 3 different radiation therapies, 4 different prescription drugs for managing the prostate cancer, and many other prescription drugs for fighting the side effects of the various therapies used. Our speaker was recently featured as the cover story in a national publication, Health Monitor, about his fight against cancer, and was the subject in a documentary now on Tubi, The Silent Killer, prostate cancer in the African American community. We would like to welcome to our panel Mr. Dwayne Charleston. Our next panelist is Deacon Martin Wright. Deacon Wright was born in Sacramento, California, where he graduated high school and attended some college. He served 10 years in the United States Air Force, and during that time served 1 year in the Middle East in Desert Storm. After leaving the Air Force, he worked at the MGM Grand Hotel Casino for 2 years before becoming a Las Vegas police officer for 21 years. After his retirement from the police department in 2020, he relocated to Houston, Texas, where he worked several small jobs after retiring before being hired with the Harris County Executive Protection Unit. His hobbies are reading, spending time with his family, traveling, and all sports. May we please welcome to this panel Deacon Martin Wright. And last but definitely not least, Dr. Karen Stewart serves as the Executive Director for the Undergraduate and Graduate Education for the Division of Research and Innovation, and the Program Director / Instructor of Biomedical Sciences in the College of Pharmacy and Health Sciences. Dr. Stewart has also held leadership positions, serving on the Executive Board of the National Tutoring Association and presently as a board member and the treasurer for the HBCU Faculty Development Network. Dr. Stewart is the recipient of a Doctor of Education, parenthetically ED, in Leadership in Higher Education from St. Edward's University, a bachelor's degree in electrical engineering, and a master's degree in counseling from Prairie View A&M, and a master's degree in second education, parenthetically math, from Texas Southern University. We would love and like you to welcome to our stage Dr. Karen Stewart. Ms. Cooper, we're in your hands.
Good morning to everybody. How's everybody doing again today? It's definitely an honor and a privilege to be here again on behalf of my alumni, Texas Southern University. Definitely want to thank Dr. Veronica again for always extending the invitation. I would also ask the extended privilege of being the second approved moderator moving forth on all panel discussions, joining my colleague, Dr. Hunter. This is a wonderful opportunity in my day-to-day work with the African American Male Wellness Agency, where we get a chance to have black men and black women to what we call release the mask, release the capes that we wear every day as black men and black women in our culture. Because in this panel discussion that you're going to be presented today, we'll get an opportunity to allow individuals of surviving prostate cancer survivors to be able to open up the dialogue about what their intellectual experiences have been individually. So we're hoping that you enjoy today's discussion. We're going to start today with Mr. Wright, our first question of today. And again, we want you guys to relax, take a deep breath, make sure you're speaking to the microphones clearly, and we'll be timely for today's session. Mr. Wright, as a prostate cancer survivor, a warrior rather, what did prostate cancer diagnosis mean to you?
Well, when I first received the diagnosis, as you know, anybody else, I'm thinking, wow, I didn't think I was going to get this. But what helped me with dealing with it was the fact that, one, as the doctors earlier had said about finding out about family history, my father, my uncles have all had prostate cancer, one. Secondly, I had always been under doctors' cares, and when I found out about it here, what really shocked me was that when my primary care doctor said, "Hey, do you know your PSA is kind of high?" which I had been having tests for over 20 years and never detected it. He detected it and said we should have it checked out. And once I had it checked out, and they found out that I did have it, and we moved forward. I mean, the initial was a shock, but also my faith in God, my wife, and what I had to help me deal with it, cope with it, and that's why I'm here today, and also like to share with others about it.
Thank you so much, Mr. Wright. You know, that means a lot to the general public, and I know as a caretaker for a father who's had 2 rounds of prostate cancer, had a kidney removal, right now wears a lifetime colostomy bag. We know that the prostate cancer awareness journey definitely wears down heavy on the black man. But I've been privileged on a recent journey to continue my day-to-day journey, walking the roads, and joining this journey with Mr. Charleston on today. So this next question, Mr. Charleston, in your journey, we know that a prostate cancer diagnosis can impact manhood, masculinity, sexuality. How did you process all these concerns through your prostate cancer journey?
First of all, excuse me if I split some verbs, subject matter verbs, or, coming after these distinguished, doctors, and then the Texas Southern debate. So I'm gonna apologize right now for splitting subject verbs and using Fender and about to, because if my girlfriend is watching, she gonna say, no, you didn't get her to talk like that. But, so I don't even know if everybody's definition of masculinity and manhood, for instance, is the same. But I was a farmer at the time that I was diagnosed, especially, and I couldn't do the work of the farm. I had to stop riding horses. I had 3 horses. I couldn't ride horses before I had the surgery. And then after I had the surgery, I couldn't ride horses. So I had to get rid of my horses. I couldn't handle goats, because when you handle the goats, you handle them by the horns. And I had a penile implant because of the severity of the cancer. And so I couldn't do what I considered manly things. I couldn't do the things. I couldn't run my farm. I had to literally get rid of everything on the farm. I couldn't ride a bicycle. I couldn't exercise. You deal with the masculinity. I started getting gynecomastia, breast enlargement, weight gain. These were the things that dealt with my self-esteem. And in the midst of taking hormone therapy, you're dealing with depression. And now you've got all these body changes and things like that. And it became enormous. And so I just basically had to get in the gym. I had to be very mindful of what I ate, very mindful of how I worked out. And what was the last one?
You talked about the masculinity, the sexuality,
yeah,
and the manhood.
Yeah, and then when you're on this long term, and I've been on cancer hormone therapy now for 15 years, and I have an implant, and so you're talking about the libido. I mean, it's devastating, all of the things that come into play. And I remember the doctor at MD Anderson told us one of the things they recommended is that you get counseling. And I'm like, I don't need no counseling. I've been married for 17 years. I don't need any counseling. 2 years later, I was going through divorce proceedings because of the mental, problems, because of the emotional, the sexual problems, and things like that. And so I just encourage men all the time to take charge, take care of yourself, and listen to what your doctors and counselors say. And so I finally took heed to that. It took me a few years, and I finally took heed to that. I started going to comedy clubs, and I started doing the things. I started going to the gyms and comedy clubs. I got an RV, and I started traveling and just kind of getting away and focusing on Dwayne.
Well, as I always share with you, Mr. Charleston, the undocumented book is awaiting.
All right.
You are a walking miracle, a walking testimony. Yeah, we just honored and privileged to be here before you today.
Yes, sir. Mm-hmm.
Our next question is for Dr. Kuminda.
Yes.
This is a 2-part question. Fear, stigma, and the uncertainty often shared the experiences amongst have those diagnosed with prostate cancer, as well as those who support them. What fear, uncertainties have you noticed from patients and their loved ones?
I have to say that the issue of fear and cancer runs all over the world. When I was in Honduras, when I was in Africa, when I'm in Houston, I have the privilege of working for veterans for over 22 years. Actually, September 30th, that's in a few weeks, I'll be there at the VA for 22 years. And most veterans are very straightforward, the straight-talking men, and the fear it should not be one of the things you expect from them. But the fear of any cancer usually stops them cold in their tracks. And the way I look at it and the way I try to understand, part of the fear is simply because of the lack of information out there, or the information which Dr. Google, which all of us have in our pockets. And I have no problem with Dr. Google, but Dr. Google is kind of a perfectionist. One of my patients came to me because he had consulted Dr. Google. He had all the urinary symptoms, and he came to me as a same-day access patient saying, "Doctor, I've prostate cancer. My life, I think, is in trouble now. Can you help me out?" When we did the lab work, and I'm glad Dr. Petaway gave the series of steps that are needed for you to do a diagnosis, this veteran didn't have prostate cancer, he had diabetes. So his problems with the urinations was something completely different. But Dr. Google had given him a run for his life for about a week. And if you would see the face of a comfortable, confident, settled man, it is this gentleman, because the fear for prostate cancer had now been replaced by the reality that they have diabetes. And for me in primary care, I deal with them as conditions. So my fight with the fear is that when you talk to people who have gone through it, when you talk to the urologists who have dealt with patients, when you talk to patients who are survivors, then you cut the fear. Because the fear sometimes makes some of our brothers, our fathers, our grandfathers not go to see the doctor. When I graduated medical school in 1990, we didn't have a lot of PSA. We had more of the DRE, the one the urologist talked about. And the men really don't like it. When I joined the VA in 2002, I still remember veterans telling me, "I'm coming, doctor, for the annual check, but no finger, please." I'm so glad to report that in 2024 now, that finger issue is not anymore on the discussion at the table. And I thank Texas Southern University to take the leadership in disseminating the information, because the more of our brethren know that there's alternatives to the test, which is painless, the better they'll come. And we all have to join hands to fight the fear. Fear for cancer is there. In fact, fear, in a way, can help you go to see the doctor. So I like to look at fear as a double-edged sword. If it takes you to see the doctor, good. If the fear for speeding enables you to lower your speed, good. If fear for smoking enables you to quit, good. If fear for mental health enables you to go see the doctor, good. But too much of it, or lack of understanding of it, can create more problems.
Dr. Commander, you made a key word. You talked about a key word in your outline there, and you utilized the word education. And I think sometimes in the African American male culture, education of this, we'll call this massive disease of prostate cancer, like you said, can kill the momentum of the self-esteem of a black man. But in a very layman terms, outside of Dr. Google, outside of AI, in your own terminology, what would be some ways that we can really promote men being intentional about timely screening as well as early detections?
In my over 20 years of practice here as a primary care, I have had the privilege to make diagnosis and have the distinct effect of giving good news to patients and bad news to patients. I've always found out that the patient who comes with me, the patient who comes to my office with his daughter, his son, his wife, his brother, is the very best. That is the environment which normally I succeed to relay all types of information to the patient in the best way. I have given patients a diagnosis of thyroid cancer in the presence of the wife and the daughter, and that man let them go and came back to tell me, "Thank you for sharing this information." It's never supposed to be a thankful moment, but when somebody who has cancer, you've given him all the bad news, comes back to thank you, it means there is something in your way or in your manner of breaking the news that helped them understand and absorb the diagnosis. So my recommendation would be that at the dinner table, at the lunch table, in our places where we share with our friends, those who have horses where you will meet, those who have clubs where you meet, being able to be deliberate in our discussion and being able to be open. I know that we come from a culture that values and knows and sets limits, and sometimes the limits are actually very tight. I would recommend that we slacken the tightness a little bit to enable us to be able to be open and to talk about it. Because when you're able to talk about it, like Dr. Johnson says, it will be easier for a father to tell the family that in my family we have this condition. It will be easier for a grandfather to tell the grandchildren this is an issue in our family. In my interaction with various patients, I've had encounters where patients tell me I was adopted and I do not know my family history. But the primary care provider then utilizes that as an opportunity to tell you, you who was adopted, who does not have the possibility of having your family, then are the very best example of a person who has to take care of everything. Now you have to fight everything. You have to assume it was there. And that gives you a chance to come to see the doctor. And the one single most important thing I can share with you all, trying to see your doctor either once a year or twice a year, or even 3 times a year for those guys who don't like to see the doctor, is one of the best things you can do. And being able to talk to your doctor is not your lawyer. Your doctor is your doctor. Talk to him everything and anything about your body, whether it makes sense to you, it doesn't make sense. Granted, most of us in primary care, we're under pressure from so many things, including payments, including whatever. Don't worry about it. When you're in the doctor's office, learn to write your list. And be like my patient A, who comes and tells me, Dr. Kumenda, today the issues are 5. Issue number 1, issue number 2, issue number 3. And then I'm able to repeat to the patient, you walked to my office with 5 issues. Have we resolved the 5 issues? And if there are any pending, do you have an understanding what is pending and why it's pending?
Thank you. Thank you so much. Before I go back to Mr. Wright, I know my mother might be watching, and I'm from the Deep South. So I want to apologize to Dr. Stewart, because where I come from, we believe in ladies first. But Dr. Stewart, I'm coming. We're going to go back to Mr. Wright, then Dr. Stewart. Mr. Wright, in your journey, we know that when an African-American male is being diagnosed, we know that this sometimes can be a very alarming subject type topic matter, especially if it's not being talked about at the dinner table, not being talked about amongst friends. But Mr. Wright, in your journey, how did you select your process of treatment options?
How I did it was one, and what I would say to each man out there that happens to go through this process, and if I could back up real quick, Dr. Johnson brought up something that back in the day, everything was taboo. I'm a young 61 years old, and I remember sitting around the table and we didn't discuss medical history or this, that, and the other. But when you say now we can have tests ran and do this and do that to find out earlier what we're dealing with, we should do it. Secondly, I had my wife, and the warrior in me had this woman, and I worried and thought, what is she going to do because now I have this disease, and what am I going to, I have to go through this. Is she going to leave me? No, she walked with me through this. I'll say to any man out there, become best friends with your wife, and you have to tell her, just like we tell the doctor, this is what's wrong with me. Right. And let's get away from the, no, I'm just going to keep this to myself. If you plan to be around a long time, you need to share it with that person. Another thing is this. We need to get away from the mindset of, I'm a man, and I hold everything in, and I'm not going to share what I'm dealing with. As we see right now, this illness is consuming us. Why? For lack thereof of several things: education, understanding, and believing that it's not going to happen to me. It's happening to us and it's taking us out. So with that being said, you know, to cope with it, to deal with it, to understand it, educate yourself, use those that are around you, husband, your wife, your spouse, your friends. You talk amongst each other. And if you've been through it, like as the Bible says, as iron sharpens iron, so does one sharpen another. We have to sharpen each other. Hopefully I've answered your question.
Thank you so much, Mr. Wright, because again, in that educational battle, I think it's very important, going back to Dr. Kamundo stated that, you know, there are modern day technology of testing that I think that's not being talked about in African American culture. And so again, in this educational journey, I think that's very important that we as men, as doctors, also share the different opportunities that are available in today's time. Dr. Stewart, we know that behind every great man there's a great woman. So in your journey with your own father, we know that treatment, identification, and other selections were very, very important in his journey to support him. What was some of the opportunities of how you had an opportunity to walk him through his prostate cancer journey?
So let me begin with, he was diagnosed twice. The first time, his support system was his brother. We were still a support, because there are 7 girls and 1 boy in my family. So we were still a support, but we had to follow his lead on how he wanted his support to look for the first time. So for the first time, his brother was at every appointment. MD Anderson, 5-something in the morning for radiation. And we may think, Daddy, you want us to come? You want us to drive you? No, we have this. But he always reported back what that looked like. We always asked him questions among the siblings. We would ask different questions, and then we would get the whole story. So that's what it was like the first time. The second time, some 10 years later, we were very aggressive, and he wanted us to be involved. However, it was still how it looked for him. Do you want us to go to the doctor with you? And so we would take turns. They knew us by name. Oh, I know this sister. I know this sister. And I know it's only one brother, so you're not that person, right? But they saw that because at that time, his brother wasn't able to do it. And so our job was to support him however he wanted that support. We didn't interject and ask those questions without asking his permission to ask that question. We let him keep his manhood, so to speak, because at that time my mom had already passed. And so for him, it was, well, you want to ask a question? And it got to that point. Or did you? So we would make a list. Dad, is there anything else that you want to ask the doctor? And then we would take that list in with us. And then we would all discuss that list. And then so whoever the sibling was that went to the doctor with him, their responsibility was report back to everybody else in detail. Yes, in detail.
Yeah, I think that's a very, very great common factor that you shared about the family dynamics of how to engage in that process. Because one thing, you know, as being an African male, you know, we are prideful, we are strong men, but at the same time, we have to be processed. You know, and I think sometimes men get to an age where we want to just say, hey, you've been diagnosed with cancer. Come on, we're going to the doctor. But at the same time, we have to understand that, you know, we have a pride issue as well. And so I really applaud the family aspect of where you guys approach that, because at the end of the day, that does affect our manhood in regards to how do we walk through those processes. So thank you, Dr. Stewart. We're going to go back to Mr. Charleston. What are some of the most important prostate cancer-related treatment and healthcare delivery experiences that have stayed with you to date?
Well, when I was diagnosed in 2009, and this is ironic because the first time when I got diagnosed, there was one doctor who I wanted to see, and I remember trying to get this doctor, and he was so booked that he couldn't see me, and I requested Dr. Pettaway, And so I'm sitting in the chair. He was sitting. It's the closest I've gotten to Dr. Pettaway. But you all don't know how great this man is. And I wasn't able to get to see him, but I did see Dr. Lewis Pisters. And Dr. Lewis Pisters, and so that was profound, the fact that I couldn't see him, but then God sent me to Dr. Lewis Pisters, and Dr. Lewis Pisters, when I was diagnosed, walked into the office, and he had seen that 16 out of 16 of my cores were positive, and Dr. Lewis Pisters, and I'm sure you know him, he got down on his knees. He said, you know, I can't cure you, and nobody at MD Anderson can cure you. He said, but the good news is that God is still in the healing business, and Dr. Lewis Pisters got down on his knees, and he prayed for my healing. And so I have known for the last 15 years is that whatever doctor touches me, whatever surgery I take or whatever chemical I take, I pray that it be at the hands and the direction of God. And so that has been important to me. And then lastly, clinical trials have probably made the difference in my life. I was kicked out of a clinical trial with a thing called lutetium-177. My PSA had shot up to almost 300. And they told me that I had metastasis all over. And so they put me out. And there was this one doctor friend of mine, Dr. Keith Crawford, who said, man, I think it's flare. And I had the privilege of talking to Michael Morris and Paul George and Dr. Korn, who's there, and all of them thought that it was metastatic spread. And Dr. Crawford said, hey, just hang in there, just hang in there. And so they put me out of the clinical trial. I came home from Dallas, I was dejected, and then all of a sudden my PSA started going down. So it goes down, and then 3 months later, I don't give up on clinical trials. I found another one with a place called Excel Diagnostics. And by January the 31st, I had metastasis in every visualized bone of my skeleton on January the 31st. People would say, man, you should be in a wheelchair. You should be in pain. And so we went through this Actinium-225, and 4 months later, and now I'm down to 2 tumors from 125 lesions and tumors. And so just letting people know that treatment decisions and options such as the clinical trials, man, it will give you extra years, and it will make a dent into mortality for all men, I believe.
Well, again, as I said earlier, Mr. Charleston, the undocumented book is waiting. Get the pen out, get the paper ready, because, again, you definitely have a true testimony. Thank you for sharing. Sure, please, definitely.
I want to acknowledge that your statement, doctors treat, God heals. That's right. Is one statement that I've always used, because Absolutely. God will use me as a vessel to treat, but only God heals. And right. Thank you for seeing it that way. Absolutely.
Dr. Stewart, you actually have the last question of the panel today. And so again, ladies, still rule. Knowing that early detection saves lives, what advice do you have for family members and loved ones to encourage African-American men to get screened for prostate cancer?
Having only one brother and him walking through that experience with my dad that last time, he knows the importance. He has 2 sons. They stay educated. I have twin boys. They stay educated. I have a grandson. He'll be 10 at the end of this month, but it's not too early to start having that conversation, right? And so for me, as a person who have this opportunity to participate in the lives of the students at Texas Southern University, not what I have planned for them, but what God has planned for them. When I come across an African-American male, we have that conversation in some way, and I don't invade, respect their dignity, but I always ask God, allow that opportunity so that we can have that conversation, because they need to know at that young age. So it's up to us to keep talking and keep talking and keep telling them how important it is to keep talking about it, for them to go to the doctor, whatever they're feeling, to do that. And so that's the important thing. We have to continue the conversation and not stop talking about it.
Correct. And to add to that, Dr. Stewart, I guess as a moderator, I would ask that as we leave today, that we start to maybe think about treating prostate cancer just outside of the September, where it's almost like it's a holiday. It's like we're only talking about prostate cancer for Black men in September. This is an ongoing issue. We need to get out of the mindset of just saying 30 days on topic. With time, we're going to have this campaign. And so that's the message I would ask that we leave with today. We have 32 seconds and counting. I'm going to ask one question from the floor before we close and be respectful of the time. Any questions from the floor for our distinguished guest today? Okay, with that being no questions, let's give our distinguished panel a round of applause.
Thank you all so very much. Please help me to appreciate these amazing panelists again, please. You all remain here because we are going to honor you for the journey that you have been through. It has not been easy, either as a support system, as a warrior, someone caring, fighting along and moving along. So please, if I may have the gift pack for each of these amazing men. Thank you very much, Olanike. Okay, and this is for you, Dr. Karen Stewart. Appreciating you, honoring you, and saying thank you, thank you, thank you. The TSU debate, they highlighted three things: love, care, and time, right? And these people up here have given each and every aspect: love, care, and time, and we appreciate that. I will take this last. Yeah, I'll take that one last. Okay, and then the next one I have here is Dr. Thomas Kumenda. Thank you very much, Dr. Kumenda. I appreciate you, sir. Thank you. And Dr. Kumenda and I, we've been working together since 2020 when we started the CMS Aggressive Prostate Cancer Study. Thank you. These were days when we were not really clear, DRE, PSA, where do we go? The Kumenda was like, Veronica, write all the grants you can write. I will write you the letter of support, and it has worked. Thank you so much. I appreciate you. Okay. All right, Deacon Wright. This is for you. Thank you for sharing your story. It's a story of strength. And we will continue to celebrate every milestone along this journey with you. And please send my regards to your lovely wife, that I say thank you to her for walking the journey with you, because it makes a difference. Thank you very much. Okay, thank you. Okay, so yes, this is a book. We need to set you up to make sure that that book is written and that it is read far and wide. You are indeed an inspiration. The doctors treat, God heals, and you are here. And there's so much more ahead. Thank you, Mr. Dwayne Chastain. I appreciate you. Thank you. And I would like to welcome upstage Dr. Pettaway. Dr. Pettaway, an amazing leader. Thank you for your leadership. Thank you for your, yes, sir, it is for you, yes. Thank you very much. If we could please have a group photo all around. You can take out your plaques if you would like to show it off so we can see it in the photos. Thank you. After the group photos, I would like to call up stage all the TSU faculty, any TSU faculty staff that is here. Please come up stage and join us. Dr. Onta, Dr. Estes. Okay. All right, yeah, you can take the first one. Okay, yes. Let me get in the middle. Awesome, thank you. CSU faculty staff. Dr. Onta, Dr. Estes, Dr. Obo, Virgil. Please join us. Okay. I know. Please. Yes. You are the coaches for the TSU debate team. Please welcome them. They wrote that amazing script, right? They wrote that awesome script that we just had from the then I would like all our speakers, Dr. Rafi, Dr. Johnson, you got it? Okay. Please join us. Sue MC, Cecilia, and that will be the last one. I like photos. Yes, thank you. Awesome. Thank you very much. Please. Thank you. This is beautiful. Absolutely. This is amazing. We have come to the close of this session. Are we able to get VP on? Perfect. Thank you very much, Cecilia. Okay, I will now turn this back to the MC to bring up VP Penn Marshall on Zoom. Thank you.
Thank you, Dr. Anjawole. And can we give another round of applause for that panel again? Such a great panel. Dr. Michelle Penn Marshall is the inaugural Vice President of Research and Innovation at Texas Southern University. She has served as co-PI for the Maximizing Access to Research Centers and the Undergraduate Research Training Initiative for Student Enhancement, both designed to expand the number of underrepresented minorities in STEM who earn the PhD or MD or PhD. Dr. Penn Marshall received her BA and MS in biology with a concentration in environmental science from Hampton University. She received her PhD in community nutrition from the Department of Human Nutrition, Foods, and Exercise at Virginia Tech. We would like to introduce or bring live on Zoom Dr. Michelle Marshall Penn.
Good afternoon. I hope everyone can hear me, and I do bring you greetings from this beautiful state of Virginia. As they introduce me, I'm Michelle Penn Marshall, and I'm so honored to serve as the inaugural Vice President for Research and Innovation at Texas Southern University. This is the only year since Dr. Ajawale, Dr. Poon, and others have hosted this event that I have not been able to attend, and I regret my absence. I'm always so pleased with all of the conversations that are held and the way that everyone expresses their experiences. Dr. Stewart, I just heard you, and I'm so honored by the way you honor your father and your siblings do as well. It is helping me as I am assisting my mother to remember hunger to allow people to have their dignity and respect, and to allow them to process diagnoses. As a resident of Surrey County, Virginia, as a person who grew up there, and in Hampton Roads, we have one of the largest prostate cancer centers in the United States. And to see the men come in and ring the bell after their treatments are over, and just the care that they have, I'm just so touched that events like this take place. I know that over the course of this particular symposium, you were able to hear the latest research and the innovative treatments. You were able to hear from each other and how we could best help people prevent from being diagnosed with prostate cancer and help them once they are diagnosed. You also had a chance to have supportive care strategies. That was the last part of what I heard at this particular event, and it truly touched my heart. I'm amazed by the work that's done at Texas Southern University and in our communities in order to eradicate chronic diseases and in order to eradicate diseases that impact people of color. Pastor Atkins Sr., I want to thank you personally and the Progressive New Hope Church and the church family for allowing this event to take place in your facility, in the church. The church is the body that is supposed to help cure the ills and the ailments of our community, to serve our community. So thank you for your leadership. Thank you for your heart. Thank you for everything that you continue to do to show Jesus to others. Today, I know that the goal was not only to share knowledge, but it was also to foster collaboration and dialogue among all stakeholders involved in the fight against prostate cancer. I enter a special thanks to our speakers, without whose expertise and insights we would not be able to move this needle, to eradicate this disease, to help people be diagnosed so that they can have a great quality of life. Thank you, community health workers, for continuing to further your education. I also extend my gratitude to the sponsors and partners, Harris County Health, TSU Center for Biomedical and Minority Health Research, and our healthcare community members, our students, our faculty who volunteered their time to provide health services. Without your generous support and your genuine interest in today's event, this would not have been possible. Together, we will continue to make significant strides in order to improve outcomes and quality of life for those affected by prostate cancer. Thank you again for joining us and for your dedication to this important cause. I really hope to be able to join you again in person in September of 2025, and I really look forward to the day when prostate cancer and other health inequities are eradicated. Have a wonderful afternoon. Thank you for spending your day and your time with us, and share the knowledge that you received with others. God bless you.
And now we'll move on to closeout announcements with Dr. Ajeole.
Please help me to appreciate once again our amazing leader, VP Penn Marshall. Thank you, VP Penn Marshall. We appreciate you. Your support and leadership has made a big difference in everything that we've had the opportunity to do here at Texas Southern University. How do you all feel about today's program? Sincere feedback, live feedback. Oh, amazing, right? Would you like us to have this again? Right? Yes, every day is a good day for prostate cancer, but guess what? We will be back. Okay, well, let me see if I can move my cursor here. Okay, hold on. Oh, right there. Got it. Okay, so save the date. Save the date is out, September 13, 2025. We will be back again, moving this information and impact along in the community. So please save the date and spread the word. And one charge that VP gave us is that everything that we have had today should not just stay within our body, right? We need to pass it along. We have leveraged technology. This information is live on Facebook. It will be edited and put right back in YouTube. So for those that were not able to join us today, share it with them so that they can continue to be a part of this conversation. As you heard earlier, we are very involved in so many other grant-funded opportunities, continually educating the community. So this is another event coming up on the 25th of September. This is a Zoom-only webinar where we are talking about social determinants of health and cancer health disparities. We didn't really talk too much about it today. Some of our speakers and panelists touched on it a bit. But if you want to know more and how environmental factors, how social determinants of health factors impact cancer health disparity, feel free to join us. It's going to be over lunchtime, so it's a good lunch and learn, right? And we would have our speaker, Dr. Onta, again. He's going to be on the panel and also speaking for us at that event. While I am aware that today's program is focused on prostate cancer, next month is Breast Cancer Awareness Month. I also have the privilege to lead a $1 million CPRIT-funded breast cancer initiative. And to God's glory, over the past 3 years, we have screened over 1,250 women at no cost for breast cancer. So we've decided to paint TSU pink. I told all the trees, all the tiger walk, I'm like, you all are going to be pink on October 18th. So please save the date. The flyers are in your folder. And we have gathered again an amazing group, survivors, expert speakers, a lot of rich information. We would have TSU debates, do their presentation again, TSU cheerleaders, TSU mascots, and TSU band. There's going to be live band performance. So, hey, my husband is a musician, okay? We met in the church. I was in the choir. He was playing the piano. So there is a part of music and art that is in us. And I believe music and art is a good way to convey information and education to the community. So we are not just going to do, didactic teaching. We'll also, bring it home with music and, everything included. So save the date, October 18th at Texas Southern University. Several mobile units like we have out now will also be there, and we would also have mammogram at no cost for uninsured and underinsured women. So save the date and join us in spreading the information around to the community. Then we're already looking into 2025. All these dates are knocking on our door. So some of us might be aware that maternal health outcome in Houston is also in a we are in a disadvantaged state when it comes to maternal child health outcome. And I see Fanace, my amazing fellow, because she was, delved all the way during this summer into that initiative. So we are again taking leadership and steps towards advancing health outcome in maternal and child health situation. So January 24th, 2025, it's a Friday, we will be having our 3rd annual maternal and child health conference. It's going to be both live and virtually, so either way, depending on your availability, feel free to join us and spread the word. Several times during today's presentation, there were multiple mentions about clinical trials. Mr. Dwayne Charleston is a live advocate, right, for clinical trial participation. You heard his testimony right there. I'm like, I need to clip that part off and just play it over and over again. I mean, look at that amazing outcome, right? But imagine if he did not participate. And when we look at the number of African American and ethnic minority participation in clinical trial, it's also very low. I said earlier during introduction that TSU has become a clinical research site. So this is going to be our 5th year of having our clinical research and engagement conference. So you don't want to miss this. It's going to be on a Saturday on Texas Southern University campus, April 19th, 2025. It's going to be a full day. Breakfast, lunch, all the educational services and everything will be provided at no cost to all attendees. So please save the date and help us to, share the word within your professional and personal contacts. All right, I want to say a big thank you again. So all this NIH funding and all the federally funded opportunities do not necessarily cover the cost of coffee, water, juice, box lunch. So there are times I have to also knock on doors. I'm not only a pharmacist, I'm also knocking on doors, asking for money. I'm like, hey, I need to get soda. There are some of my sponsors, they're like, hey, Veronica, what do you need? I'm like, hey, I need money for food. Okay, can you help me? And, big thank you to MD Anderson, Houston Methodist, and some of all our other funded programs for supporting today's event. And to all our partners, Prostate Health Education Network, the church that we are in today, CVS Aetna with their mobile unit outside, Harris County Public Health. I want to pause here and really give a good applause to Harris County Public Health. Dr. Kumenda, if you remember, when we were closing out on the study 2 years ago, we had that gap of mobile units, right? Then I had a meeting with Dr. Petaway when he shared his experience with me with the success of mobile unit screening, several years back. So I'm like, okay, I need resources. Guess what? I engaged with Harris County Public Health. Please help me to appreciate Ms. Davis Kalondria. That lady, we had like a 30-minute meeting. And she's like, okay, Veronica, I got it. And they've never offered PSA screening before. And because of this call, because of the motive behind this intention and me sharing the data, they developed a pathway for PSA screening. And they are doing it live outside today for the very first time in the community. So please, thank you, Harris County Public Health. You guys are amazing, and we appreciate you. To all our vendors, please, they will be in the vendor area shortly. Feel free to continue to engage with them so that way we can get more information across the board. And once again, saying a big thank you. Dr. Pon had to leave early, but Dr. Pon is our amazing associate director, supporting and helping us. Dr. Ogbo, Dr. Jones, Virgil, Dolores, I might miss a few people's name, Cecilia, Sneha, oh my God, Sneha, where are you? Love you, Sneha, thank you so much. All these amazing faces. And Cassie, you guys probably got emails from Cassie, right? Cassie is at a family reunion. She's not here with us in person, but we could not have done this without the support of these staff members. So I do truly appreciate them. And Texas Southern University is a big institution, right? Multiple departments, multiple units, but we have favor and blessing to be able to work across all these multiple units, KTSU, Division of Research and Innovation, Provost Office, everyone in between, providing support and, helping us to make impact in the community. Please help me to appreciate our volunteers. Please. The volunteers help us, to package the folders, the food, everything in between. I am really grateful. Consolation X, you guys do an amazing job. Thank you, all the promotions, the MailChimp. I'm like, hey, boost it up. Let's make sure we get the word out. Thank you, Carlos. Thank you, Deborah. I appreciate you guys very, very much. And most importantly, each of you in the audience, right? We could put this amazing event together and not have anybody, right? But you guys left everything. And hey, it's a beautiful day outside. You could be doing anything else, but you decided to join us in person. And to several others that are online too, thank you very much for being a part of our event today. QA, social media, and survey announcements. Repeating that again, your survey is very important. Again, we are grant funded. and we stay very responsive to the need of the community. So please complete that survey online, preferably. If you want to complete it paper format too, we have a few printed papers available if you would like to complete your survey by paper. Okay, lastly here I have all the health mobile units are outside in the parking lot. Then we have several of the vendors will be, to my right here after the closing prayer. Please feel free to engage with them and get more information. Okay, it will be my pleasure now to bring up stage Deacon Wright as we do closing prayers.
Let me say a few words, if I will, before I know we're on a time sequence here. I want to take, on the behalf of Reverend Atkins and the members and family of Progressive New Hope, we thank you for allowing us to be part of this each year. We hope that we can continue to work with you, get the word out, help one another. The Bible says, let us consider how we may spur one another on towards love and good deeds. Let us not give up meeting together as some are in the habit of doing, but let us encourage one another all the more as we see the days approaching. With that being said, we thank you for once again allowing us. We thank you for the team, the doctors, all of you. We thank TSU. And now let us close with the word of prayer. Father in heaven, we come, we thank you for this day. We thank you for all that you've done and all that you're going to do. We ask that we will continue to touch lives spiritually, physically, mentally, and do it the way that you will have us to do. Watch us as we leave this place, and that we can return to our homes and to our families, but also that we will spread the word, spread love, spread joy, and spread peace. Now bless us as we have food today, Father, and bless us all as we go. We ask these blessings in Jesus' name we pray. Amen.
Hi there. Thank you so much for joining us for today's program. My name is Veronica Ajewale, and I want to say a big thank you for engaging with us. I am certain that you have had a lot of great information that has increased your level of awareness about prostate cancer. Like our speakers and panelists said, early detection saves life. So help us in passing this information forward when you follow us on our social media handles at CECTX Southern U. You will continue to have access to today's program, and you can share it with your family members, loved ones, and people within your circle of influence. Encourage somebody to take an action towards advancing health equity in prostate cancer. I want to say thank you to our panelists, our speakers, our partners, to all our interns, volunteers, to the leadership of Texas Southern University, to our staff and our faculty. Thank you so much for supporting us. Today's program would not have been as successful as it is without your support. And I want to encourage you to continue to support us and continue to share the word in the community. You can find us on our social media platforms at CECTX Southern U. Thank you for joining us, and we look forward to a successful engagement in the future. Thank you.